And I extend warm welcome to Dr. Narendra Gowda sir, whose participation and involvement is going to brighten and improve our day. And I request Dr. Shivu Arikeri sir to welcome sir with token of love. And I also welcome Dr. Rajshekhar Ganigir sir, guest of today's function, and I request Dr. Ravi Chavan sir to welcome sir with token of love. And I welcome all the members of Lima Women's Forum District Branch Ballari for this event. Now I invite Dr. Chaitra for Dhanvantari Stavana.
नमामि धन्वन्तरिम् आदिदेवं सुरासुरैर्वन्दितपादपद्मम् लोके जरारुग्भयमृत्युनाशम् धातारमीशं विविधौषधीनां धन्वन्तरिं रमानाथम् सर्वरोगनिवारकम् आयुर्वेदप्रवक्तारम् वन्दे पीयूषदायकम् सर्वे जनाः सुखिनो भवन्तु सर्वे सन्तु निरामयाः सर्वे भद्राणि पश्यन्तु मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः.
I request all the dignitaries present on the dais to light the lamp.
Farida.
Now I request our principal sir and Dr. Rajshekhar Ganigir sir to felicitate sir. So please accept our heartfelt greetings. Now I would like to call Dr. Rashekar Ganigir sir to talk about the event.
ಈ ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷತೆ ವಹಿಸಿರುವಂತಹ ಡಾಕ್ಟರ್ ಮಾಧವ ದಿಗ್ಗಜರವರೇ, ಬಳ್ಳಾರಿ ನಗರದ ಖ್ಯಾತ ಹೃದಯ ರೋಗ ತಜ್ಞರು ಮತ್ತು ಸ್ನೇಹಪೂರ್ವಕ ಒಬ್ಬ ವೈದ್ಯ ಅಂತ ಹೇಳಿದ್ರು ತಪ್ಪಾಗ್ಲಿಕ್ಕಿಲ್ಲ, ಡಾಕ್ಟರ್ ನರೇಂದ್ರ ಗೌಡ್ರವರೇ, ನನ್ನ ಮಹಾವಿದ್ಯಾಲಯದ ಎಲ್ಲ ಪ್ರಾಧ್ಯಾಪಕ ಸ್ನೇಹಿತರೆ ಮತ್ತು ಆತ್ಮೀಯ ವಿದ್ಯಾರ್ಥಿನಿಯರೇ, ನಿಜವಾಗ್ಲೂ ಬಹಳಷ್ಟು ಸಂಭ್ರಮ ಪಡುವಂತ ಒಂದು ಕೆಲಸ. ಯಾಕಂದ್ರೆ ಡಾಕ್ಟರ್ ಎಂ ಈಶ್ವರರೆಡ್ಡಿ ಮೆಮೋರಿಯಲ್ ಒಂದು ಸೀರೀಸ್ ಅನ್ನ ಹಾಕೊಂಡಿರ್ತಕ್ಕಂಥದ್ದು ಬಹಳಷ್ಟು ಸಂತೋಷ. ನನಗೆ ಆಶ್ಚರ್ಯ ಆಯ್ತು. ಆಕ್ಚುಲಿ ಎಂ ಈಶ್ವರರೆಡ್ಡಿ ಅಂದಾಗ ಅವ್ರು ಹುಟ್ಟಿದ ದಿನಾನೂ ಅಲ್ಲ, ಅವ್ರು ಸತ್ತಿದ ದಿವಸನೂ ಅಲ್ಲ. ಇದೇನಂತ ನಾನು ಆಶ್ಚರ್ಯಪೂರ್ವಕ ನಾನು ಶಿವ್ ಕೇಳಿದೆ. ಯಾಕಂದ್ರೆ ಶಿವ್ಗೆ ಎಲ್ಲ ಪರ್ಟಿಕ್ಯುಲರ್ ಗೊತ್ತಿರ್ತಾವೆ, ಜಯಂತಿ ಇದು ಏನು ಅಂತ. ಯಾಕಂದ್ರೆ ನಾವಿಬ್ರು ಕೂಡ ಈಶ್ವರರೆಡ್ಡಿ ಅವರ ಶಿಷ್ಯರೇ. ಕೇಳಿದಾಗ ಇಲ್ಲ, ಯಾವ್ದು ಇಲ್ದಾಗೂ ಕೂಡ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಹಮ್ಮಿಕೊಳ್ಳುವಂಥದ್ದು ಅತ್ಯಂತ ಗೌರವ ಸಲ್ಲಿಸ್ತಕ್ಕಂಥ ಕೆಲಸ. ಸಾಮಾನ್ಯವಾಗಿ ನಾವು ಜಯಂತಿ ಒಂದು ದಿವಸ ಅಥವಾ ಸತ್ತಿದ ದಿವಸ ನೆನ್ಸ್ಕೊಂತೀವಿ ಬೇಕಾದಷ್ಟು ಜನರನ್ನ. ಬಟ್ ಯಾವ್ದು ಇಲ್ಲೇ ಇರುವಂತ ನೆನ್ಸ್ಕೊಳ್ಳುವಂಥದ್ದು ಅವ್ರು ಏನೋ ಒಂದು ಉತ್ತಮವಾದಂತ ಕಾರ್ಯ ಮಾಡಿ ಹೋಗಿದ್ದಾರೆ ಸಮಾಜಕ್ಕೆ ಅನ್ನುವಂಥದ್ದು ತೋರಿಸ್ತದೆ. ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಹಂಚ್ಕೊಂಡಿರ್ತಕ್ಕಂಥದ್ದು ಬಹಳಷ್ಟು ಸ್ವಾಗತಾರ್ಹ. ಮತ್ತು ಈ ಸೀರೀಸು ಇದೇ ತರ ಮುಂದೆ ಹೋಗುವಂತದ್ದಾಗ್ಲಿ. ನರೇಂದ್ರ ಗೌಡರ ಬಗ್ಗೆ ಹೇಳ್ಬೇಕಂದ್ರೆ ನಿಮ್ಗೆಲ್ಲ ಆಶ್ಚರ್ಯ ಆಗ್ಬೋದು. ಇಲ್ಲಿ ನಾವು ಬಹಳಷ್ಟು ಜನ ಇದೀವಿ, ರೈತರ ಮಕ್ಕಳು, ಟೀಚರ್ಸ್ಗಳ ಮಕ್ಕಳು. ಈಗ ನಾನೊಬ್ಬ ರೈತರ ಮಗ ಇದ್ದೀನಿ, ಟೀಚರ್ಗಳ ಮಕ್ಕಳು ಇರೋಂಥವ್ರು ಸಾಕಷ್ಟು ಜನ ಇದೀವಿ. ನರೇಂದ್ರ ಗೌಡರು ಏನಂದ್ರೆ ಬಹಳಷ್ಟು ನಮ್ಗೆ ಹೆಮ್ಮೆ ಪಡುವಂತ ಒಬ್ಬ ಟೀಚರ್ ಮಗ, ಸಾಮಾನ್ಯ ಕುಟುಂಬದಲ್ಲಿ ಹುಟ್ಟಿರ್ತಕ್ಕಂಥ ಒಬ್ಬ ಟೀಚರ್ ಮಗ ಅನ್ನುವಂಥದ್ದು ನಾವು ಎಲ್ಲಿಯೂ ಕೂಡ ಅವರು ಯಾವ್ದಾದ್ರು ಡೊನೇಷನ್ ಕೊಟ್ಟು ಹೋದವರಲ್ಲ. ಎಲ್ಲಾ ಹಂತದಲ್ಲೂ ಕೂಡ ತಮ್ಮ ಪ್ರತಿಭೆಯ ಮುಖಾಂತರ ಅವರು ತಮ್ಮ ಒಂದು ಇಲ್ಲಿವರೆಗೆ ಬಂದಿರತಕ್ಕಂಥ ಸಾಧನೆ ತಮ್ಮ ಪ್ರತಿಭೆಯ ಮುಖಾಂತರ ಮಾಡಿದಂಥವ್ರು. ಅವರು ನಮ್ಮ ಜೋಗಿಹಳ್ಳಿಯಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ನವೋದಯ ಏನು ವಿದ್ಯಾಲಯ ಇದೆ ನಮ್ಮ ಸರ್ಕಾರದ್ದು, ಆ ವಿದ್ಯಾಲಯದಲ್ಲಿ ಓದಂತವ್ರು. ಸಾಕಷ್ಟು ಸಾರ್ ಒಡನಾಡಿಗಳು, ಸರ್ ಜೂನಿಯರ್ಸು, ವಿಶೇಷ ಜೂನಿಯರ್ಸ್ ನಮ್ಗೆ ಬಹಳಷ್ಟು ಪರಿಚಿತರು. ಈಗ ಹಳ್ಳಿ ಆಗಿರ್ಬೋದು, ನಮ್ಮ ಕೊಟ್ರೇಶ, ಜಮ್ಮನಗೌಡ, ಚಂದ್ರಪ್ಪ, ಶ್ರೀನಿವಾಸ್ ಜೂಟೂರ್ ಅಂತ ನನಗೆ ನಮ್ಮ ಕೊಪ್ಪಳದ ಕಾಲೇಜಲ್ಲಿ ಅವರು ಕೂಡ ಒಂದು ಪಾರ್ಟ್ನರ್ ಆಗಿದ್ದಾರೆ. ನಮ್ಮ ಅಗಸ್ತ್ಯ ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ನಾವೇ ಕೊಪ್ಪಳದಲ್ಲಿ ಮಾಡ್ತಾ ಇದ್ವಿ. ಅದರಲ್ಲಿ ಬಹಳಷ್ಟು ಒಳ್ಳೊಳ್ಳೆ ಒಬ್ಬ ವೈದ್ಯರನ್ನ, ಒಳ್ಳೊಳ್ಳೆ ಪ್ರತಿಭಾವಂತರನ್ನು ಕೊಟ್ಟಿರ್ತಕ್ಕಂಥ ಜೋಗಿಹಳ್ಳಿ ನವೋದಯ ವಿದ್ಯಾಲಯದಿಂದನೇ ಸರ್ ಬಂದಿರತಕ್ಕಂಥವ್ರು. ಮತ್ತು ಸ್ನಾತಕೋತ್ತರ ಪದವಿಯನ್ನ ಮುಗಿಸಿ ಅದರಲ್ಲೂ ವಿಶೇಷವಾಗಿ ನಮ್ಮ ಬಳ್ಳಾರಿ ನಗರಕ್ಕೆ ಈ ವೈದ್ಯರ ಹೃದಯ ರೋಗ ತಜ್ಞರ ಒಂದು ಕೊರತೆ ಸಾಕಷ್ಟು ಕಾಡ್ತಾ ಇತ್ತು. ಎಷ್ಟೋ ಸಂದರ್ಭದಲ್ಲಿ ನಾವು ಏನ್ ನೋಡ್ತಾ ಇದ್ವಿ ಅಂದ್ರೆ, ಬಳ್ಳಾರಿಯಲ್ಲಿ ಒಂದೇನೋ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಆಗಿದೆ ಅಂದ್ರೆ ಅದನ್ನ ನಾವು ಏನಾದ್ರೂ ಮಾಡಿ ತಗೊಂಡು ಹೋಗ್ಬೇಕು, ಈ ಕಡೆ ಬೆಂಗಳೂರೇ ಮುಟ್ಟಿಸ್ಬೇಕು. ಎಷ್ಟೋ ಸಂದರ್ಭದಲ್ಲಿ ಅದೇನು ಗೋಲ್ಡನ್ ಅವರ್ ಅಂತ ಏನ್ ಕರೀತಾರೆ, ಆ ಅವಧಿಯಲ್ಲಿ ಪೇಷಂಟ್ ಇಲ್ಲೇ ಸತ್ತು ಹೋಗ್ತಾ ಇದ್ದಿಲ್ಲ, ಆನ್ ದ ವೇ ಇನ್ನೇನ್ ಹಿಂಗೆ ಹೋಗಿ ಚಳಕೆರೆ ದಾಟಿರುತ್ತೆ ಮತ್ತೆ ಬಾಡಿ ತರ್ತಕ್ಕಂಥ ವ್ಯವಸ್ಥೆ ನಮ್ಮ ಬಳ್ಳಾರಿಯಲ್ಲಿ ಇತ್ತು. ಮತ್ತು ಆ ತಜ್ಞ ವೈದ್ಯರ ಕೊರತೆ ನಮ್ಗೆ ಯಾವತ್ತೂ ಕಾಡ್ತಾ ಇತ್ತು. ಅಂತ ಒಂದು ಆ ಕೊರತೆಯನ್ನ, ಆ ಒಂದು ಏನು ವ್ಯಾಕ್ಯೂಮ್ ಅಥವಾ ಒಂದು ಗ್ಯಾಪ್ ಅಂತ ಹೇಳ್ತೀವಿ, ಅದನ್ನ ತುಂಬಿರ್ತಕ್ಕಂಥವ್ರು ಡಾಕ್ಟರ್ ನರೇಂದ್ರ ಗೌಡರು. ಬಳ್ಳಾರಿ ಹೃದಯಾಲಯದಿಂದ ಪ್ರಾರಂಭ ಆಗಿ ಇವತ್ತು ಬಳ್ಳಾರಿ ಹೆಲ್ತ್ ಸಿಟಿ ಅನ್ನುವಂತ ಆಸ್ಪತ್ರೆ ಏನಿದೆ, ಇವತ್ತು ಸಾಕಷ್ಟು ಜನರಿಗೆ ಸೇವೆಯನ್ನು ಕೊಡ್ತಾ ಇದೆ. ಅದರಲ್ಲೂ ವಿಶೇಷವಾಗಿ ನರೇಂದ್ರ ಗೌಡರು ಹೆಂಗಂದ್ರೆ ರಾತ್ರಿ 1 ಗಂಟೆ ಫೋನ್ ಮಾಡಿದ್ರು ರೌಂಡ್ಸ್ ಮಾಡ್ತಾ ಇರ್ತಾರೆ. ಅವರು ಮನೆಗೆ ಹೋಗಿರಲ್ಲ, ತಮಾಷೆ ಮಾಡ್ತಿರ್ತೀವಿ, ಯಾವಾಗ ಗೌಡರ ಮನೆಗೆ ಹೋಗ್ತಿರಿ ನೀವು ಅಂತ ಹೇಳಿ. ಸೊ ಅಂತ ಒಂದು ಸೇವಾ ಪ್ರವೃತ್ತಿಯನ್ನು ಹೊಂದಿರತಕ್ಕಂಥ ನರೇಂದ್ರ ಗೌಡರು ಇವತ್ತು ಬರ್ತಾ ಇರೋದು ಕೇಳಿದಾಗ ನಂಗೆ ಆಶ್ಚರ್ಯ. ನಾನು ಶಿವಗೆ ಅಂದೆ, ನಾನು ಅಂದ್ರೆ ಸರ್ ಅಷ್ಟು ಫ್ರೀ ಮಾಡ್ಕೊಂಡ್ ಬಿಟ್ಟಿದಾರಲ್ಲ ಅಂದಾಗ ನನಗೆ ಅನಿಸ್ತು, ಭವಿಷ್ಯ ಅವರಿಗೆ ನಮ್ಮ ತಾರನಾಥ ಆಯುರ್ವೇದ ಮಹಾವಿದ್ಯಾಲಯದ ಬಗ್ಗೆ ಬಹಳಷ್ಟು ಅಭಿಮಾನ ಅವರಿಗೆ. ಅದರಲ್ಲೂ ವಿಶೇಷವಾಗಿ ಇಲ್ಲಿ ಕೂತಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ಆಯುರ್ವೇದ ವೈದ್ಯರು, ನಮ್ಮ ನ್ಯಾಷನಲ್ ಇಂಟಿಗ್ರೇಟೆಡ್ ಮೆಡಿಕಲ್ ಅಲ್ಲಿ ಇರ್ತಕ್ಕಂಥವ್ರು ಮತ್ತು ನನ್ನ ಆದಿಯಾಗಿ ಎಲ್ಲರೂ ಕೂಡ ಸರ್ ಬಹಳಷ್ಟು ನಾವು ಚಿರಪರಿಚಿತರು. ಅವ್ರದ್ದು ಎಷ್ಟು ವಿನಮ್ರತೆ ಅಂದ್ರೆ ಹೇಳ್ತೀನಿ. ನಾನು ಒಂದ್ 2-3 ಸರಿ ಹಾಸ್ಪಿಟಲ್ ಅಡ್ಮಿಟ್ ಆಗಿದ್ದೀನಿ. ಅವ್ರ ಹಾಸ್ಪಿಟಲ್ಗೆ ನಮ್ಮ ಮಗ ಕೂಡ ಇದ್ರ ಟೈಮಲ್ಲಿ ಏನೋ ಡೆಂಗ್ಯೂ ಆದಾಗ ಕೂಡ ಆಗಿದ್ದ. ಅವ್ರದ್ದು ಹೆಂಗಿರ್ತಂದ್ರೆ, ನಾನೊಬ್ಬ ಅಧ್ಯಾಪಕ, ನನಗೂ ಅವ್ರಿಗೆ ಏನಂತ ಏನು ವಿಶೇಷ ಇಲ್ಲ. ಇವರೆಲ್ಲ ಹಳ್ಳಿ, ಇವರೆಲ್ಲ ನಂಗೆ ಬಹಳ ಆಪ್ತರು. ಅವರು ನಾವು ಹೋದ್ರೆ ಹಿಂಗ್ ಕೈ ಕಟ್ಕೊಂಡು ನಮ್ ಮುಂದೆ ನಿಲ್ಲುವಂತ ಅಷ್ಟೊಂದು ನಿಸ್ಪೃಹ ಜೀವಿ, ಸ್ನೇಹ ಜೀವಿ ನಮ್ಮ ನರೇಂದ್ರ ಗೌಡರು. ಇವತ್ತು ಅವ್ರು ಬಂದಿದ್ದಾರೆ. ಅವ್ರ ಜ್ಞಾನದ ಒಂದು ಉಪಯೋಗ ನಮ್ಮೆಲ್ಲರಿಗೂ ಕೂಡ ಆಗ್ಲಿ. ಈಶ್ವರರೆಡ್ಡಿ ಅವ್ರ ಪರಿಚಯ ಇಲ್ಲಿ ಇದ್ದವ್ರು ಬಹಳ ಜನಕ್ಕೆ ಇಲ್ಲ. ಒಂದ್ ದಿವಸ ಈಶ್ವರರೆಡ್ಡಿ ಅವ್ರ ಬಗ್ಗೆ ಒಂದು ಕ್ಲಾಸ್ ತಗೊಳ್ಳುವಂತ ಕೆಲಸ ಮಾಡೋಣ. ಈಶ್ವರರೆಡ್ಡಿ ನಾನು ಯಾವಾಗೂ ಹೇಳ್ತಾ ಇರ್ತೇನೆ, ಬಂದಾಗ ತಾರನಾಥರ ಬಗ್ಗೆ ಹೇಳ್ಬೇಕು. ನಮ್ಮ ಮಹಾವಿದ್ಯಾಲಯ ಬಂದಂತ ಮಕ್ಕಳಿಗೆ ತಾರನಾಥರ ಬಗ್ಗೆ ಹೇಳಿದಾಗ ಮಾತ್ರ ಈ ಮಹಾವಿದ್ಯಾಲಯದ ಬಗ್ಗೆ ಅವ್ರ ಅಭಿಮಾನ ಬರ್ತದೆ. ಸುಮ್ಮನೆ ಯಾರ್ದೋ ಹೆಸರು ಇಟ್ಟಿದ್ದಾರೆ ಅಂತಿಕೊಂಡು, ಒಬ್ಬ ರಾಜಕಾರಣಿ ಅಲ್ಲ ಅವರು, ಆಯ್ತಾ, ಒಬ್ರು ದೇವತಾ ಮನುಷ್ಯ ಅವರು. ಅವ್ರ ಹೆಸರಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ಕಾಲೇಜಲ್ಲಿ ನಾವು ಓದ್ತಾ ಇದೀವಿ ಅನ್ನೋದಕ್ಕೆ ಹೆಮ್ಮೆ ಪಡ್ಬೇಕಾದ್ರೆ ಅವ್ರ ಬಗ್ಗೆ ತಿಳ್ಕೊಬೇಕಾಗ್ತದೆ. ಹಾಗೇನೆ ಎಂ ಈಶ್ವರರೆಡ್ಡಿ ಅವ್ರ ಬಗ್ಗೆನೂ ಕೂಡ ಬರುವಂತ ದಿವಸಗಳಲ್ಲಿ ನಮ್ಮ ಅಲುಮಿನಿಯಿಂದ ಮಾಡುವಂತ ಕೆಲಸ ಆಗ್ಲಿದೆ. ಶಿವ ಸರ್, ಕೊಟ್ರೇಶ್ ಸರ್ ಮುಂದೆ ಬರುವಂತ ಈಶ್ವರರೆಡ್ಡಿ ಅವ್ರ ಬಗ್ಗೆನೂ ಹೇಳ್ಬೇಕಾಗುತ್ತೆ. ನೀವು ಹೋಗ್ಬಿಟ್ರೆ ಮುಂದೆ ಈಶ್ವರರೆಡ್ಡಿ ಅವ್ರದ್ದು ಹೇಳೋರು ಯಾರು ಇರೋದಿಲ್ಲ. ಅವ್ರ ಸೇವೆ ಏನು, ಅವ್ರದ್ದು ಏನೋ ನಿಸ್ವಾರ್ಥ ಸೇವೆ ಏನೈತಿ ಮಹಾವಿದ್ಯಾಲಯಕ್ಕೆ ಅನ್ನೋದು ತಿಳಿಸ್ಲಿ. ಮತ್ತು ಇಂಥ ಕಾರ್ಯಕ್ರಮ ಇನ್ನೂ ಹೆಚ್ಚು ಆಗ್ಲಿ ಅಂತ ಹೇಳಿ ಅವರ ಒಂದು ಭಾಷಣಕ್ಕೆ ಅನುವು ಮಾಡಿಕೊಟ್ಟು ನಾನು ಮಾತಾಡಿದ್ದಾರೆ.
Now I request in our beloved principal sir, Dr. Madhav Diggavi sir, for presidential address.
Om Shri Dhanvantare Namaha. Most respected cardiologist of the city, Dr. B. Narendra Gowda ji, Dr. Rajshekhar Ganagher, my friend and head of the Department of PG Studies in Raviguna, the NEMA office bearers, Dr. Virupaksh Vastrat, Dr. Ratan Gowda ji, Dr. Mahesh, and NEMA Women's Forum President Dr. Farida, and Dr. Hema Desai and Dr. Savita, and all the faculty members, postgraduate scholars, internees and students. Today is a big day for Tarnath Government Ayurvedic Medical College. Since 2 years, there was a plan to call Dr. Narendra Gowda sir for a guest lecture on cardiac issues. I was continuously trying, but today the time has come. In our PG departments, cardiac diseases research work is going on. Many of the patients come to our hospital with diabetes and hypertension, and invariably they will have left ventricular hypertrophy, old MI or IHD as one of the consequences when they come to our hospital. Many of the stroke patients who come to Tarnath Hospital for Pakshagata, they will have a cardiac illness inside. Atherosclerotic disorders, ischemic heart disease, post-CABG cases, they are regularly reported to our hospital. A vertical longitudinal research activity is going on in our department with respect to coronary artery disease, myocardial infarction and ischemic heart disease, left ventricular hypertrophy and ejection fraction issues. So the postgraduate scholars and internees and teachers are fortunate today to have a wonderful feast of knowledge on cardiac illnesses by a practical person who is daily attending more than 8 to 10 angiographies, cath labs. One interesting thing is Dr. Narendra Gowda sir is our IEC member, Institutional Ethical Committee member, and sir will be supporting us, our students. In future, whenever sir gets time, we can have a continuous medical education program. And also our students can make use of cardiac cath lab. We can request our Dr. Narendra Gowda sir to allow our PG scholars who are working in this regard with short batch can go and see the practical work what they do. They can be exposed to see the angiographies, CABGs and evaluation patterns which are current trends without taking much of the time. It is for you. This activity is for students. It is organized by the college and with the cooperation of NEMA Ballari District Branch and NEMA Women's Forum. So make use of it. Have interactions. Continuously rapport with sir. Whenever you get time, go and discuss about your patients, your clinical activities with sir. Sir is very kind enough to help us. With this, I request Dr. Narendra Gowda sir to visit our institute again and again whenever sir gets time. Thank you, sir. Thank you, and all.
Speaker of today's event, Dr. Narendra Gowda sir, DM, MD, consultant cardiologist, VIMS Ballari, is a highly dedicated and skilled cardiologist with 10 plus years of experience diagnosing and treating wide range of cardiovascular conditions, proficient in performing diagnostic tests such as ECG and interpreting results to guide and plan treatment, known for providing compassionate care to patients and efficiently communicating complex medical information. Sir has done his MBBS in the year 2002 from VIMS Ballari, and he has done his MD Internal Medicine from Gandhi Medical College, Bhopal in the year 2010 and DM Cardiology in the year 2016 from Sri Jayadeva Institute of Cardiovascular Sciences, Bangalore. Sir is proficient in thrombolysis, minimal invasive technique, ECG, diagnosing the conditions and interpreting test results and prescribing medications. Sir has 10 plus years of professional experience, served as consultant physician in Zindal Sanjeevani Hospital, Torangallu from 2009 to 2010 and as assistant professor in VIMS Ballari from 2009 to 2014 and also as resident cardiology in Sri Jayadeva Hospital, Bangalore from 2014 to 2016 and sir is presently working as a consultant cardiologist in WIMS Ballari. So the function of education is to teach one to think intensively and to think critically. Intelligence plus character is the goal of true education. And with this anecdote, without much delay, I invite Dr. Narendra Gowda sir to take up the session that you all have been waiting for. And over to you, sir.
Good morning, everybody. ಎಲ್ಲರಿಗೂ ಶುಭ ಮುಂಜಾನೆ. So, I want to just tell three things before starting my topics. I was very happy. The meeting hall is called Mantana Hall. I was very happy with the name. And I was asked to everybody is leaving slippers, footwears and coming inside. It's one of our tradition. It's so maintained well. And after that, our postgraduates and students who has converted my this very difficult file into presentable. Actually, they got so much of expertise there. Okay, very thanks. Because in one of my talk, actually, when I gave in IMA, I couldn't convert. So the talk I gave without any audiovisual aid, and talk actually became more. I mean, I had to give it for 1.5 hours because when visual aid is there, we can limit our talk. So just to tell that I'm a orator kind of a person. So I don't want to waste your time. I want to just talk practical things. That's why I kept the name practical considerations. Okay. So what is coronary artery disease, epidemiology, risk factor, pathogenesis, what is the spectrum of the disease, how it presents, and how to treat it, how it is treated as today in Bellary and around the world. Okay. So I want to make it very, very simple. So these slides are only for support sake. Okay, I will be telling what is practical and what is required for you people. So atherosclerosis means you know that athero means it's a gruel. That means a curd-like thing. Athero curd is gatti ada sclerosis. That is called atherosclerosis. It can happen in the any artery, starting from your head to toe, and it can cause so many diseases. If it happens in the head, brain, it can cause stroke, ischemic stroke. If it occurs in coronary arteries, it will cause myocardial infarction or ischemia. So there are two words. You all know that in pathology you would have read. Ischemia means there is only, on demand, there is no supply of the blood and oxygen. Okay. So the person is stable at rest. But when he walks or when he climbs the stairs, he will get chest pain. Why? Because when he climbs, the heart rate will increase. The myocardium requires more oxygen. So when the brain cannot, heart starts to contract more and beat more, but it is not getting enough oxygen or enough metabolites because the artery is stenosed. Okay, so stenosed like 60 to 70% like that. So then they will have only a pain on exertion. So that is the ischemia. Infarction means you all know that read in second year pathology means dead cells. Again, infarction means it can be coagulative necrosis and other things. Okay, so more in myocardium actually the coagulative necrosis occurs. Okay, so like that it can present with coronary vasculature. It can cause angina, myocardial infarction, sudden death. Okay, many times you would have heard in your this thing. A person was sitting suddenly. Okay, he was trying to walk and he had sudden chest pain and death. Okay, most commonly in our old Kannada movies, Hindi movies, used to see somebody, son will tell something, father will get heart attack. Okay, so like that sudden death. So then cerebral vasculature, if atherosclerosis occurs, it can cause TIA or stroke. Peripheral, claudication, gangrene. Okay, in upper limb or lower limb more common. So renal, if it occurs in kidneys, blood vasculature, then it can cause hypertension. So epidemiology, like the disease is very much prevalent. Actually, Indians are becoming capital of both diabetes and also cardiovascular disease. We already become capital. There are so many people having cardiovascular disease. Okay, so it is one of the leading cause of death in United States. This is American slide. Okay, none of the slides are mine. Please bear with it. Only my words are mine. Okay, so and it's almost similar, but in India actually we have got this cardiovascular disease. If you take coronary artery disease, forms the major junk. Okay, in India also it's same thing. But also the rheumatic heart disease is very less in developed countries, but it's still a very much problem in India. But of late, the percentage of rheumatic heart disease is coming down. So then diseases of the arteries, high blood pressure, coronary heart failure, congestive heart failure, stroke. So these are all the manifestations of coronary artery disease. And we know that it's the number one killer. Okay, it's the first killer in India. In many audits, it has been shown that it is the number one killer, and the second comes the cancer and other things. Okay, so what are the underlying risk factors? So what are the risk factors? There are three type of risk factors: underlying, major, and emerging. So underlying risk factors are obesity, disinclination to exercise. That means not exercising enough, and atherogenic diet. So then comes the major traditional risk factors. These are called traditional risk factors. This is written in classic all our textbooks. Age, gender, males, cardiac coronary artery disease is very common, and dyslipidemia. So high LDL cholesterol, low HDL cholesterol. So that means LDL cholesterol is more, and HDL cholesterol is less. HDL cholesterol is also called as good cholesterol. It's also called high density lipoproteins. Actually, in our India, the heart attacks or what you call myocardial infarction or ischemia is more common in younger people when compared to Western countries. Almost like we are 10 to 15 years earlier. And even when our people go to America and Japan or any developed country, when compared to their people, again, our people will have earlier to them, in spite of the environmental and diet changes also. So, because there is an underlying genetic thing. And also, especially, I think I am the only cardiologist in Ballari or anywhere who doesn't write cholesterol because I don't believe the reports many times. And after believing also, my treatment is not going to change. And moreover, the blood test is costing so much. So actually, how do our labs do, except in 2-3 labs, in my lab and Amrut lab and 2-3 labs, LDL should be measured directly. But nobody measures LDL directly because it becomes costly. So everybody uses Woodmark formula. You just go through. That's calculated. You see many labs, they will write LDL, bracket L, C and the further. That means calculated. It's not real one. So HDL is also many times calculated. Also, actually HDL should be directly measured. So because in Indians, what is the most common problem is triglycerides will be very high. Okay. So in Western countries and many studies, they are told triglyceride is not at all a risk factor for a man. High triglyceride is risk factor for only pancreatitis and other things. But in India, it has been shown. It's also called Indian dyslipidemia. Recently, if postgraduates try to Google such good things in Google, okay, like what are the current Indian guidelines on IALI, one association is there, Indian Association of Lipid Disorders. Actually, their new definition is like in India, even just triglyceride will be high. LDL will be many times normal. But in spite of that, why the people are getting coronary artery disease is because we have got whatever the LDL, the type is very much different from Westerners. That's why even at the lower level of LDL, people are getting. And HDL is always low in Indians. I have not seen any person, even some people come and say that I take yogic diet, I live like a sattvic diet, I live like yogi. Instead of that, I see many times their HDL is around 20-30. Okay, so HDL again is very low in Indian population. So about two things we can't reverse: age we cannot reverse, gender we cannot change. So these are irreversible risk factors for heart attack. There are diabetes, hypertension, smoking, and family history of premature CAD in first degree relative. First degree relative means siblings, father, mother, blood relative, first degree blood relative. So if the first degree relative, when we call premature, is when the person, like suppose the mother of that patient person, individual, is having a coronary artery disease or any atherosclerotic disease. Atherosclerotic means, as I told, stroke, renal, PAD, or whatever. So if they are having less than 55 years, 65 years for females, mother or sister, and father or brother is having less than 55 years, then it is called premature. Because in females, the estrogen is protective against atherosclerotic disease. But after 45 to 55, again, their incidence is also becoming almost equivalent. But to be honest, even I am seeing regularly village ladies, women, they are having regularly heart attack and many times they don't come to the hospital. Slow ongoing coronary artery disease, they are coming directly with heart failure, sir. So this I am seeing at 35, 40 years. Why? Because they are addicted to that snuff, nashpudi. Okay, that is very common. So this marketing and bad habits have infiltrated into our society, like they cannot be taken away. And the marketing is in such a way that so village people, the males will be continuously 24 into 7. They will be keeping the tobacco, chewing tobacco, and the females will be keeping the snuff. So they are so addicted. So I am seeing 28 years lady coming with breathlessness. Just I saw echo. I was really like wondering because only 10% of ejection fraction, and we can't do anything. We can't do neither angiogram. So many times some people ask because once there was some faculty related to your hospital came. So the coronary artery was diffusely diseased from the end, beginning to the end. So that time we can't do anything. We can neither we can do surgery nor we can do medicines do work wonder there, and lifestyle modifications, diet. So we believe it or not, after 3 years again we took angiogram of him. So many lesions were cleared. So like that, the changes can be if the lifestyle and this habit and all those things can be changed. Definitely we can reverse in many people also. So diabetes, hypertension, smoking, these are all the major traditional risk factors. Now emerging risk factors. Now many people with the becoming cardiologist is not tough, but people make it tough. So in midnight, 2 o'clock, somebody is sending me WhatsApp. Sir, ನಾನು HSCRP, tell me then, what should I do? So then somebody sends sir homocysteine. He is 66. You see, homocysteine, none of the studies it has been proved that it's a risk factor. They are all the additional corroborative risk factors. Suppose it is high means you take care of yourself and don't unnecessarily get panicked and don't go and do all the tests. Okay. In particularly LPA. So in Indians actually we say LPA is again high risk factor. We have seen many people normal lipid profile, everything normal, just LPA is raised and people are having stroke or this thing. So recently I had a one young patient around 35 years. So he was like, so do whatever the test you want. So we did, only LPA was raised. And apolipoprotein A and B, it is not mentioned in this slide. Okay. And fibrinogen levels and all, it's not a. So now currently among this list, LPA, apolipoprotein A and B, homocysteine, HSCRP, they are all the good guides. Like they can tell that a person is going to have this thing. So in particular, one family known to me is a doctor. So he was worried because his all brothers and parents, they all underwent some angioplasty or bypass at young age. That means I told no what is mean of young age. In females less than 65, males less than 55 years. They underwent the procedure in this age group. So it is called premature coronary artery disease or atherosclerotic disease. So he asked, we will test everything. So when we tested, only LPA was raised. So if we can identify such people, definitely putting them on atorvastatin and other drugs will help them in preventing the future coming this thing. So this I already covered practical things. So hypertension, you all always remember, rise in systolic hypertension causes stroke, rise in diastolic BP causes myocardial disease. Okay, because most of the filling of coronary arteries occurs during diastole. We all know that. We all read in our cardiac cycle in physiology. Okay, so diastolic high BP more commonly is associated with cardiac. It's not a rule, but in stroke usually it is a isolated systolic hypertension. Okay, so this is how, and then comes the smoking. It increases the cardiovascular risk by twofold, and even 1 to 2 cigarettes per day is also this thing a risk factor. Even sitting beside a smoker is also a risk factor. You can see articles related to it from PubMed. Okay, not from any Google Scholar or AI. Okay, now AI also it's coming. Sir. So already Google was throwing so many things. Now AI it will also give so many things. Okay, so thing is we have to become that same Hamsa Kshira Nyaya. Whatever we want to take, we have to take. So suddenly what happens when we want to see some article, some WhatsApp message will come, we will go into that and we will forget this. So this also happens. So I think better go to books rather than the phone. Okay. Obesity. Obesity is an independent risk factor for cardiovascular disease. So measures, you know that as a postgraduates and this thing, you know, measuring a BMI, simple measurement, that is the height divided by, weight divided by height in meter square, and waist hip ratio. So these are all the again risk factors. Synergy of risk factors means if the multiple risk factors are there, means they are at the higher risk of coronary artery disease at any point of their lifetime. So then comes like in so diabetes mellitus, like we take it as diabetes mellitus as a, if somebody is diagnosed diabetes mellitus more than 2 years, we take it as like he has got already one atherosclerotic artery disease somewhere. So now the current guidelines, ADA guidelines says anybody more than 40 years, even the LDL cholesterol, everything is normal, give statins. So if somebody asks what is the normal level of LDL, I see many people even with the self lifestyle changes and some Ayurvedic medicines and also sometimes some statins, they come, they say, son, LDL 40 there. So normal range written in Amrut lab or our lab, wherever it is 40, 40 to 100, okay, or less than 130 is okay, okay. So LDL level, so you can write it up. So less than 130 is normal for general population, less than 100 for diabetics, less than 70 is for one who has got already some heart attack or CV or something. Means anywhere some atherosclerotic disease has occurred, means less than 70 is preferable. And we say lower the better. That means, so why lower the better? So minimum I am seeing some patients even having 24, 25. It's good. Okay. Why? Because when we were in our mother's womb, the fluid in which we are bathed is actually having LDL of 20. Okay. Till 20. So in that fetus level, our blood will be having LDL level of 20. Okay. So LDL at 20 is also very good. HDL high is very preferable. More than 55, we say in females, and more than 45 in males is a protective against coronary artery disease. So it's a good cholesterol. So HDL, LDL, I see whenever somebody keeps, now all these days it has become very fashion. People, they go and they do 150, 30, 50, sometimes even 100 pages tests from some therapist somewhere. Okay, they pay some 8,000, 10,000, they get all the tests and come. It becomes so headache to see it. I don't know, now somebody has informed those people. So now they are writing in first one page only whatever abnormal values only they will write. So he did not write it. So particularly like us who have come from middle class family, why we think why they are wasting so many papers actually, because we call papers as Saraswati. Why they are wasting so many papers? Because anyway that fellow is going to throw it somewhere, and it is just we are indirectly causing deforestation. So that all tests are not necessary. So just a fasting lipid profile, which is done at a good lab where LDL is directly measured and HDL is also directly measured, and we can get that value, HSARP and homocysteine. We can do only if there is suspicion. Suppose a person wants, because his first degree relative or somebody has got coronary artery disease, then we can do it. Okay. Then comes metabolic syndrome. So I think we are all well versed with metabolic syndrome, especially postgraduates. So because there was a one thinking, there are many people who are getting heart attack. There are many people who are getting stroke. There was one of the biggest study called inter-arch study. It was actually included more than I think 5 to 10 lakh people. In that, actually, there were 20,000 people from our India and also around 1,000 people from our Jayadeva Institute only. In this biggest inter-arch study, they did the study. They were only assessing what are the risk factors for MI and stroke. So they found the maximum number of people who had those events were having no risk factors. So that's why our professors used to say, so no risk factor is a big risk factor. So we can't be like, we can't say like, since we are not seeing, we can't say like, okay, it's not there. So there were people started thinking why. So then they found out this term metabolic syndrome, which there since almost 2008 to 10. So abdominal obesity, waist circumference in men more than 40, women more than 35 inches, triglycerides more than 150 milligrams per deciliter. So here you see, in this we don't take LDL. So they thought even if the normal LDL, people are having problem. So that's why they researched and they found out this metabolic syndrome. That means if you are obese, if your triglycerides are high, and if your HDL is low in men less than 40, women less than 50, and BP more than 130 or 85, okay, and fasting glucose more than 100, need not be diabetic. It can be just 106, 108, 110 also. If 3 or more of these are positive, then the person is considered to have metabolic syndrome. So again, they found out metabolic syndrome is, you see many people who are having stroke, this thing, they will tell, ಏನಪ್ಪ ಎಲ್ಲ ಚೆನ್ನಾಗಿದ್ದ, ಏನ್ ತೆಳ್ಳಗಿದ್ದ, ಫಿಟ್ ಆಗಿದ್ದ, ಆದ್ರೆ ಯಾಕಾಯ್ತು? So they might be having this metabolic syndrome. Okay. So then comes other this pathogenesis and are very beautiful actually. So you go through good textbooks, so you will find out how the atherosclerosis evolves. Actually, it starts at when you are kids actually. Okay, when you are 6 or 7 years, the fatty streaks start in our coronary arteries or whatever the arteries. So how it occurs is the foam cells get collected. In the foam cells, LDL get collected. They become fatty streaks. As we age 35 to 40 years, so they go on accumulating this atheroma, that is gravel-like thing. And one fine day, so they are matured into the plaques. So these plaques are again divided into vulnerable plaques and stable plaques. So we see many people. So what happens? I will tell you some practical things. So few days back, a person he was working as anesthesia in some US. Okay, he has come with 92-year parents. He was telling, "Sir, ನಮ್ಮ ತಂದೆ ತಾಯಿ ಒಂದು ಆಂಜಿಯೋಗ್ರಾಮ್ ಮಾಡಿಸ್ಬಿಡಿ." ನಾನು ಹೇಳಿದೆ, "ಸರ್, ಆಂಜಿಯೋಗ್ರಾಮ್ ಇಂಡಿಕೇಶನ್ ನೋಡ್ಬೇಕು. ಯಾವಾಗಲೂ ನಾವು ಓದಿರೋದನ್ನ ಮರಿಬಾರ್ದು. ಸೊ ನಾವೇನು ಓದಿರ್ತೀವಿ ಅದನ್ನ ಸೈಂಟಿಫಿಕ್ ಆಗಿ ಆಚರಣೆ ಮಾಡಬೇಕು." ನಾನು ಹೇಳಿದೆ, "ಸರ್, ಅವ್ರ ಸಿಂಪ್ಟಮ್ಸ್ ಏನಾದ್ರು ಯಾಕೆ ಮಾಡ್ತೀರಿ? See, they are 93 is his father, 89 is his mother. They are able to walk." So I told, "Sir, just to ECG echo ಮಾಡಿ, ಏನಾದ್ರು ಇದ್ರೆ we'll treat with medicines. Since they are not having symptoms, they are neither having angina, not having anything, why you want to just do angiogram?" Because in angiogram also, 1 in 10,000 person can die while doing procedure. So in cardiac, every procedure is risk. So in cardiology, we say no risk hai to ishq hai. So in cardiology, so there is lot of risk. So we have to tell every patient. That's why for angiogram, you will be taking this thing, signature for consent, because we don't know. You engage the artery, it can raise a plaque, artery can close, patient can die. This happened once when I was working in Jayadeva. The person yesterday, one day before, he did 18 meds TMT, perfectly normal. Okay, he's only around 34, 35, related to some Jayanagar MLA. When he came for angio was done, all normal coronaries, shifted. I was working in post-care. So I saw, okay, post-care means 50-20 patients will be there. Jayadeva government hospital. So per day there will be more than 200 to 300 procedures. So I was just seeing, everything was there. I told, okay, shift him to special ward. In Barashtrige, the person is nowhere. So we did CPR, all those things. Then we took the patient. So we tried to cannulate. No, nothing was there. So these things can occur even if coronary. I told, no, sir, angiogram is not required. So then he told, sir, uribal ಪರವಾಗಿಲ್ಲ, ನನ್ನೊಂದು ಸ್ವಲ್ಪ ಎಕೋ TMT ಮಾಡ್ತೀರಾ ಅಂತ. Okay, ಆಯ್ತು, we'll do TMT. So we did TMT. So he's a football player, daily runs 10K. He looks more fit than me, you, everybody. He looks like some Hollywood hero. And that guy, believe it or not, low workload positive. So we took him for angio. I was like, Narendra, I believe you so much. Okay. So what will you do to your brother? You do that thing to me. I told, okay, sir, we'll do angio because there is an indication we will do. We did angio, triple vessel disease, critical, 99%. And that guy is not having any symptoms. Okay. So one small plaque, vulnerable plaque. So these people are like stable plaques. They will be a thick cap, dense extracellular matrix, and less repeat rich core. Means it will be like a organized atheroma plaque. So it's not going to like open up. So there are vulnerable caps. That means that collagen laid is less. So there is a thin fibrous cap. There is a large lipid core. Lipid means it will be very soft and high macrophage content. That is foam cells, what I told. So these things, suppose some exertion because of the shear stress of the blood over the plaque, it can open up anytime. And this guy is so stable. I told he is like a risk factor, the critical disease. So even if one artery closes, he is going to die anytime. So we sent him, he underwent bypass, he was happy. Okay. So these things can happen. So that's why we should do the things only when there are clear indications. Anything. For example, even putting IV cannula also, we should always tell the patient, ಒಂದು ಸೂಜಿ ಹಾಕ್ತಿದೀವಿ, ನೀವು ಸ್ವಲ್ಪ ನೋವಾಗುತ್ತೆ. You should always be like telling the patient. Okay. So then comes so spectrum of coronary artery disease. So what is the spectrum? That means we came to know from childhood only the plaques can develop. Then what is the spectrum? So there is something called silent ischemia. Okay, a police officer, he is just about to retire in 1 month. He came to me, sir, ನಾನು ಒಂದ್ಸರಿ ಎಲ್ಲ ಟೆಸ್ಟ್ ಮಾಡಿ ಆಯ್ತು ಸರ್ ಮಾಡೋಣ ECG ಮಾಡಿದ್ವಿ ನಾರ್ಮಲ್ ಎಕೋ ನಾರ್ಮಲ್ ಸೊ ದೆನ್ ಈ ಟೋಲ್ಡ್ ಐ ಡು TMT ಸೊ ಸಾರಿ ECG was normal. I told him okay we'll do echo ECG echo both are normal. TMT was positive. We took him for angio, there was triple user disease. So another police officer came. He told, I am also going to get retired. Please, you do all the tests. ECG, MI changes, echo, LV dysfunction, and only 30%. He studies sir, again symptoms in the I told, I shown in the video, sir, your echo is like this. So why? So this is called silent ischemia. Like the diabetic people, they will not be able to sense the ulcers in their food. The same thing, they will be having myocardial ischemia, ongoing infarction. ಯಾವಾಗ ಒಂದ್ಸರಿ ಬರ್ತಿರ್ತಾವ ನೀನೋ ಕೊಡ್ಬಿಟ್ಟು ಆರಾಮಾಗಿರ್ತಾರೆ. So something like that. Or they think some gastritis, they will take some pantoprazole, Pandy, MSD, the most I can say abused drugs on the earth now. So they will take and then they will be thinking I am okay. Or many times there will be no symptoms at all. And then they come with silent ischemia. So directly LV dysfunction. That's what I told about this 28-year lady also, that village lady. So not having any symptom till she became breathless, till the heart became scarred. Myocardium was scarred. There is no myocardium only. There is only thin fibrous tissue, and she was having LV failure. And then when they were asking sir how it happens, it's silent ischemia. That means suppose you do angio of those people, they will have diffuse coronary artery disease and some collateral something that is keeping them alive. Okay, so that is silent ischemia. Then comes your chronic stable angina. That means they are perfect at rest. ECG will be normal, echo will be normal. They will be getting angina. Angina means there should be three things. Typical angina means three should be there. First is the nature of pain. That means what is the nature of the pain? It is either squeezing, discomfort, or lynching. And the lynching at the machine where they used to lynch the mugging ಅಂತೀವಲ್ಲ ಕುತ್ತಿಗೆ ಆ ಥರ ಇಲ್ಲಿ ಫೀಲಿಂಗ್ ಆಗ್ತಾ ಇರುತ್ತೆ. ಆ ಲೈಂಚಿಂಗ್ ಟೈಪ್ ಆಫ್ ಪೇನ್. ಮೆನಿ ಟೈಮ್ಸ್ ಯು ಆಸ್ಕ್ ದೆಮ್ ಪೇನ್ ಆಗ್ತಿದೆಯಾ, ನೋವಾಗ್ತಿದೆ ಅಂತ ಕೇಳಿ ಕನ್ನಡದಲ್ಲಿ. they will tell ಸರ್ ನೋವಾಗ್ತಿಲ್ಲ, ಒಂಥರ ಆಗ್ತಾ ಇದೆ, ಬಂಡೆ ಮೇಲಿಟ್ಟಂಗಾಗುತ್ತೆ, ಫೀಲಿಂಗ್ ಲೈಕ್ ಪ್ರೆಷರ್. So myocardial ischemia is typically defined as these things: discomfort, lynching, or some heaviness, or some pressure-like symptoms, or some this thing. Rarely as pain. So in our classic textbook description, that is the nature of angina. First is nature, then is precipitation. Precipitation means it increases or it appears only then there is exertion. Okay, and then is it is relieved with either rest or nitroglycerin. So if these all the three things are there, then it is called typical angina. But in our Indian setup, many times what happens, atypical angina is very common. That means only two of the three things will be there. Okay, they will tell, or in ಹೋಗ್ತಾ ಇದ್ದೆ ಹಿಡ್ಕೊಂಡಂಗೆ ಆಯ್ತು ಹಿಂಗಾಯ್ತು, ECG ನೋಡಿದ್ರೆ MI ಇರುತ್ತೆ. Atypical angina is very common in our Indian setups. Okay, especially in females. Atypical angina is more common in females. They will be telling some vague symptoms. You take on ECG and echo and drop T, it will be positive. So we are seeing like that. So atypical angina, typical angina. So when that angina is there for prolonged time, it is called chronic stable angina. That means he is able to walk from Taranath gate to here without pain, but when he climbs this stairs, he is getting pain. So that is called stable angina. Okay. So then comes unstable angina. Unstable angina means he was able to do the things properly. He was able to walk from year to year since many days, but today he is getting pain only walking half the distance. That means he is getting pain at less distance traveled with the less strenuous activity, and the pain is increasing in severity, duration, and it is lasting for more than 10 minutes, 15 minutes, 30 minutes. Then it's time to go and take ECG and get the further treatment. It's called unstable angina. So, but still in unstable angina, if you do troponin T, it will be negative. If the troponin T or troponins are positive, then it is called NSTEMI. So NSTEMI means non-ST elevation MI. That means in ECG, ST is non-elevated. It is simple thing. Then comes ST elevation MI. That means the patient is having chest pain, ongoing, continuous. It's making him run to a hospital, and it's making him to concentrate only on the pain, and he runs to the hospital. When you take a ECG, there is ST elevation. That means patient is going up, you have to catch him down. Okay, ST elevation means patient is going up, you have to do something. So whereas NSTEMI means there will be ST depression. That means patient needs rest, you put him on the bed, start the treatment. Okay, so like this, STEMI and unstable angina. These things are classified. So our patient can be belong to anything. Okay, so traditionally it was being classified as no ST elevation and ST elevation. ST elevation means urgent, you have to do something. You have to give the 5 drugs, the drugs which are you are supposed to give in acute MI, I will be telling you, and then either do thrombolysis or you do primary angiogram and angioplasty. So reperfusion, reperfusion means the closed artery or opening, and you are resetting the reperfusing the the myocardial area. So that is called reperfusion strategy. It can be either the thrombolysis or it can be with the angioplasty. So non-ST elevation in my again unstable angina where troponins are negative. That means infarction has not yet occurred, but there is a severe grade of ischemia. Okay. Now clinical presentation again, as I told, women the angina is most common, whereas MI is less common because of these all histogenic and other things. And whereas in men, MI is most common first event rather than angina. Then comes acute MI. So there is a definitely improved mortality in even in our India and also in Bellary, as Kanigar sir was telling. So previously, as sir might be remembering, when we were interns, that time if any person come in chest pain, take ECG and discuss about ECG for half an hour. Okay. MI ಆಗಿದೆ ಇಲ್ಲ RV ಹಿಂಗಿದೆ ಆಗಿರ್ಬೋದು ಏನಾಗಿ ಇನ್ನೊಂದ್ಸರಿ ಸಾರ್ ಒಂದ್ಸರಿ ಕೇಳ್ಬಿಡ್ರಿ. So there will be some senior will be there or some expert will be there. So like that it used to get discussed. By the time we will give some nitroglycerin and give bed rest, give some sedative. Only aspirin we used to give. So apart from that, nothing. Then by the time we became interns, 98, 2000, streptokinase came into Bellary market. That time streptokinase was like a wonder drug. Okay, like people used to say thrombolysis naditade, as if on gunfight AK-57 naditide. So it was to be like that. But now it has become very commonplace. I am very happy that even in all hospitals, many hospitals, thrombolysis people are able to do, and we are able to save the lives. Okay, so then comes even now we have got even advanced things like you can take the patient for primary angioplasty if the thrombolysis is not working, or if the patients are affordable, we are directly taking the patient to angioplasty. Okay, so differential diagnosis always must. So whenever you are thinking of some diagnosis, always we should keep our brain for differential diagnosis. So that's what I say. ನಾವು ಬರೀ ಇದೇ ಆಗಿದೆ ಅಂತಂದೇಳಿ ಹೋಗ್ಬಾರ್ದು, ಇನ್ನು ಏನಾರು ಆಗಿರ್ಬೋದಾ ಅಂತ ಯೋಚನೆ ಮಾಡ್ಬೇಕು. ಅದು ಬಹಳ ಇಂಪಾರ್ಟೆಂಟ್. ಸ್ವಲ್ಪ ಅದಕ್ಕೆ ಕನ್ನಡದಲ್ಲಿ ಯೋಚನೆ ಮಾಡ್ಬೇಕು ಅಂತ ಹೇಳ್ತೀನಿ ಸರ್ ನಮ್ಮ ಸ್ಟೂಡೆಂಟ್ಸ್. ಯಾಕಂದ್ರೆ ನಾವು ಇಂಗ್ಲಿಷ್ ಯೋಚನೆ ಮಾಡಿದ್ರೆ ಇಲ್ಲಿ ನೆನಪಾಗಂಗಿಲ್ಲ. ಬರೀ ಯೋಚನೆ ಮಾಡ್ತಿರ್ತೀವಿ, ಪೇಷಂಟ್ ಎಮ್ಮ ಅಂತಂತಿರ್ತೀವಿ. ಎಮ್ಮ ಇಲ್ದೇನೆ ಇರ್ಬೋದಲ್ಲ. ಈಗ ಎಷ್ಟೋ ಜನ ಬರ್ತಾರೆ, ಜಸ್ಟ್ ಈಸ್ ಓನ್ಲಿ 18 years, ಎಲ್ಲೋ ಕ್ರಿಕೆಟ್ ಆಡ್ತಾರೆ, ಸೊ ಚೆಸ್ಟ್ ಪೇನ್ ಅಂತ ಬರುತ್ತೆ. ECG ಮಾಡಿದ್ರೆ MI ತರನೇ ಇರುತ್ತೆ, ಬಟ್ ಇಟ್ಸ್ ನಾಟ್ MI. ಸಿ ಈಸ್ ಓನ್ಲಿ 18 years. Okay, ಈಸ್ ನಾಟ್ having all the 3 typical features of angina. Unnecessarily, why you want to do all the tests? So many times it will be a hyper, what we call in youngsters hyperpolarization ಅಂತ ಹೇಳ್ತೀವಿ. Okay, abnormalities. They are very common in young people. And less than 18 years, so many times ECG ಮಾಡಿಸಿರ್ತಾರೆ, TO inversion ಎಲ್ಲ ಕಾಣ್ತಿರುತ್ತೆ. So they said it as MI. So it's not MI. It is a juvenile TO inversion, which is actually normal for what you say like less than 18-year people. Okay, so these normal variations also we should be knowing. Only then we will be not doing unnecessary investigations and unnecessary management. That's most important. So the most common difference in pericarditis, pulmonary embolism, pneumothorax. Okay, few days back one person came. So we did ECG. He's having ST elevation, some ST elevation, depression, pain ಇರ್ತದೆ, ಫುಲ್ ಜಬರ್ದಸ್ತ್ ಪೇನ್ ಇರ್ತದೆ, ಸ್ವೆಟ್ಟಿಂಗ್ ಆಗ್ತಿದೆ, ಎಲ್ಲ ಆಗ್ತಿದೆ. ಇನ್ನೇನು ನಮ್ಮ thrombolysis ಮಾಡಬೇಕು, just auscultate, there was less air entry. So suspected ಇಲ್ಲ, ಸುಮ್ಮನೆ ಎಕ್ಸ್ರೇ ಮಾಡಿ pneumothorax. So okay, so like this we can see. That's why whatever your teachers are teaching you, those things are going to help you. Clinical examination, history, you should always be the best in that. Okay, only then your investigations and treatment will be better. So many people what they do, they directly they even don't see the patient. E test mode, R test mode. Always start with general physical examination. You believe it or not, one lady, she was rushed from Monacolmuru for telling no, you have got MI, you go. So midnight they have come. So next day morning, just from the distance you can tell she is anemic. So just by seeing her face you can tell she is anemic. I told okay, ನೋಡೋಣ madam, first ಇದೆಲ್ಲ blood test ಮಾಡೋಣ. Hemoglobin is 4. Okay, so that itself is causing ECG changes. Okay, you treat that first. So whatever you learn pickle in your second MBBS, second year Typical means pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. These things you never miss. That's why whenever the patient comes, you always see the patient from top to bottom and how they walk to you. So there itself, many times you will be catching the diagnosis. What I mean to say is clinical examination in any patient, surgical, medical, or whatever, so it's very important. Okay. Many times with that, actually, we are able to avoid unnecessary investigations, unnecessary treatment, and those things. Then just esophageal spasm. And the nice thing is esophageal spasm will present like a chest pain. Okay. But when you give nitroglycerin also, it will get relaxed because esophagus also relaxes. So many times that also can be a differential diagnosis. So examination, we all know, like the patient will be restless, having sweating, associated sweating and all those associated symptoms. So ECG. So just I want to cover ECG itself is a very big topic, but still I will cover very basic thing. When you do ECG, so if there are always look for ST elevation like this. I think my marker you are unable to see. You are seeing able to see lead 1 and AVL. Okay, there is ST elevation. Okay, always look for ST elevation. ST elevation in AVR is common. Okay, ST elevation in other leads, if you are able to see. So then here you can see, here you can see ST elevation. Okay, so always whenever somebody you take a ECG, look for ST elevation. Apart from AVR, AVR only sorry, ಏನು ಇಲ್ಲದೆ ST elevation ಇರಬಹುದು. AVR and E lead. Okay, so if it is there, then it is ST elevation. Suppose these things are not there, you think if there are ST depressions like this, down sloping, ST is down sloping. Okay, in this ECG it's good. Here you can see there is ST depression. Okay, this is suggestive of non-ST elevation. But here you can see in 2, 3 and AVF, ST is elevated. Okay, so ST is elevated. So the ST is nothing but from the end of the R wave to the T wave segment. So here ST is elevated, 2, 3 and A wave. So if it is ST is elevated in 2 or 3 leads, then it is called ST elevation. If ST is depressed like this and there are no ST elevation, then it is called non-ST elevation MI. So it is simple. So ECG, again it also tells which artery might have been blocked, which wall of the artery is blocked. So you might ask like why there are 12 leads. So there are all the 12 leads represent each area of the heart. 2, 3 AVF, it's very easy to remember. 2, 3 AVF. F means foot, no? Inferior limb. Foot is down. Okay. So easy to remember. 1 and AVL, L means lateral. So lateral wall MI, ST elevation will occur in lateral wall MI in 1 and AVL. 1 and AVL, lateral wall. 2, 3 AVF, inferior. You can write it down and memorize. In sleep also you can tell. Okay. And you know like how the leads are placed. Suppose if you have seen how the leads are placed. V1, V2, V3, anterior. So if there is ST elevation in these leads means anterior MI. Suppose V5, V6 are kept in the lateral side, anterior and mid axillary line. So if the ST elevation of some changes in V5, V6, then it is lateral MI. Very easy to remember. Nothing to by heart. Okay, just by practical things you can remember. Then comes your serum cardiac markers. So as you all might be knowing, so till 2, 3 years back we were having these tests, creatine kinase, CKMB, and then came myoglobin and all those things. Okay, so creatine kinase and CKMB, please do not write. Okay, until otherwise you have got some doubt with the troponins. Okay, so because they are of not of any value. I see many people writing and it's only unnecessary waste of blood to and to do. Okay, so you did not do that. No? Then comes your troponin T and I. So this troponin T is very what I say like very good important test. Okay, and we should know everything important about this troponins. So troponins are released by ischemic or infarcted myocardium. So troponin I and T are measured in from the serum. Okay, so then what is HS troponin? HS means high sensitive troponin. A test is called high sensitive troponin if the test is ready able to measure troponins even in normal people. That means even in a normal people like me and you who doesn't have a MI or heart attack, if you measure, there will be some troponin levels. So then the test is called HS troponin. So there is a cutoff value above which only it is called abnormal. For troponin T all over the world, it is fixed value, 14 nanograms per ml. Okay. But the problem is the Roche is having only one patent and each charging around 400 rupees for a lab, and every lab almost charges around 600 rupees for troponin T in Bellary. Okay, only 2-3 places we have got Roche machine. So cutoff value all over the world is same, 14 nanometer, because they are going to identify particular only one epitope or antigenic surface of that troponins. Okay, so that's why it's same. So troponin T value is same. But recently they have released one more bedside troponin test. Okay, there actually 50 is the cutoff value. Above 50 means considered as MI. Whereas troponin I, you might be asking, like troponin I value varies from lab to lab. In Amrut lab itself, there are two troponin I machines. So cutoff value is always different because troponin I, the machine is cheaper. So many labs in Ballari we have got troponin I. Okay. So troponin I, the problem is troponin I is many times it can be false positive, many times it can be false negative. So measuring troponin T is desirable, but the machine is very costly. So almost 15 to 18 lakh, and it is like maintaining a white elephant in your hospital. So, but we have to maintain. So we have got troponin T machine in our hospital. So then comes troponin I is also quite good. I am not telling, but it can miss sometimes. So troponin I is also from a good this thing like Abbott architect and those machines. It's definitely it's reliable. So HS troponin T when it's available you do, and troponin I also useful in some conditions. So what happens always in what my teacher has taught is whenever a test is stored, whenever a drug is stored, we should always know what are the false positive, false negative, adverse reactions, common side effects. Okay, if you know these things, so then we will excel in our practice or excel in our life. Okay, suppose a test is done, we should always know what is when it will become false positive. So troponin T, though it's a good test, it can be false positive in so many things. In septicemia, okay, in renal failure. Okay, these are the two common conditions. Okay, so patient is having some renal failure, or patient is admitted in ICU, with septicemia, and troponin T is positive, and they call cardiac, sir, please come and see, troponins are so high. Many times nothing will be there. Okay, it's a false positive. So troponin T can be a false positive in so many things. Then comes troponin I, that is also same false positive in many things, but troponin I is relatively more sensitive, more good when the patient is having renal failure. Okay, so there it comes. And in renal failure patient, then how to evaluate MI? Suppose the creatinine is 4 5. How to evaluate for MI means you do pair test. Always you say beauty of life is when you are doing something in serial manner, as sir was telling, vertical study means when do at particular time in intervention and again you do and see. After 6 to 8 hours, if the value is rising, means then he has got MI, heart attack. Otherwise, he is not having. So like this, always period values repeating in series, minimum 6 hours. After you have to repeat and see if it is rising or not. Then comes yesterday we had one patient a few months back. He was having only migraine on left side, sir. His complaint was that he is having his own relative is a physician. He has gone into many times. He is continuously eating that migraine, and also he is taking this what you say vasograin and all those things. Every time, whenever he is exerting, whenever he is climbing the stairs, he is having migraine. So his typical complaint is only when I'm exerting, I'm having migraine. So then with this complaint, he has gone to many people. In that fine night, he is having sweating everything. So his relative told you go and get admitted there. Just do one troponin. When the troponin was done, it was 450. It was so high value. Then what we did, by the next day ECG were also showing evolved changes. So always don't be mesmerized that first ECG is normal. Okay, it is not MI. It's not like that. Okay. So recently one corporator, he came with chest pain. He came with only sweating. Okay, only sweating, no other symptoms. He's telling some discomfort, some mostly indigestion and sweating. First ECG is normal, second ECG is normal. So by the time our the referring doctor could identify there is something wrong, I am missing. So he referred the patient to me. Okay. So then the patient came to me, my almost 30-40 minutes. ECG again normal. Then I thought something is give echo. So when I saw with the echo, there was wall motion abnormality was there. Wall motion means that particular area of the myocardium was not contracting, so there is myocardial ischemia. So I started him on thrombolysis. Then after 1 hour, ECG started showing the changes. There is always something called latent period. Okay, ಇವತ್ತು TB ಬಂದಿದೆ ಅಂದ ತಕ್ಷಣ X-ray TB ಬರಲ್ಲ. So it takes some time to show that radiological signs. Okay, so like that, every test has got some latency period. So ECG also minimum half an hour to 1 hour only it becomes this thing. People say echo can detect very early, but problem is echo many subjective problems. Some person will say there is MI, another person will come and say no, there is no MI. Okay, it all depends on how you are trained and how you look at the echo of the patient. Okay, so earliest is echo, then comes your ECG will be positive, like our carburetor case I told. Then you are also having double SL, he underwent later stenting, that's a different story. Then comes troponins. You see in this migraine-like patient, so only that day the troponins were done, it became positive, and ECG is serially done showing the MI changes. So then he took him for it. There was a LED blockage was there. We put him stent, and his migraine disappeared. Okay, when he was a very classical case. When I was doing the case, as soon as the balloon went into that stenosis area, it was blocking. When we are doing angioplasty, also there is some amount of myocardial ischemia. So when you are putting, you are having migraine. So when you dilated, his migraine disappeared. So it was a very nice case actually. Even his ST, everything used to become normal and monitor. So like that. So any test. That's why when this all thing comes in your mind, because when your clinical examination history taking is perfect. Okay, your history taking should be always like it should include everything. Many times what happens, you see, I always ask 3 questions in their mother tongue. Okay, whatever the patient mother tongue is. ಫಸ್ಟ್ ಬಂದಾಗೆ ಅವ್ರು ಹೇಳ್ತಾರೆ ನಿಮ್ಗೆ ಏನು ತೊಂದರೆ ಆಗಿದೆ ಎಲ್ಲ ಹೇಳ್ತಾರೆ. ಅದಾದ್ಮೇಲೆ ಕೇಳ್ಬೇಕು ಇನ್ನೂ ಬೇರೆ ಏನಾದ್ರು ತೊಂದರೆ ಇದೆಯಾ. ಓನ್ಲಿ ದೆನ್ ಯು ವಿಲ್ ಟೆಲ್ ಐ ಹ್ಯಾವ್ ಡಯಾಬಿಟಿಸ್, ಹೈಪರ್ಟೆನ್ಷನ್, ದಿಸ್ ಐ ಹ್ಯಾವ್ ಅಂಡರ್ವೆಂಟ್ ಆಲ್ ದಿಸ್ ಸರ್ಜರಿ. ಓಕೆ, ಅದರಲ್ಲಿ ಯು ವಿಲ್ ನಾಟ್, ಯು ವಿಲ್ ಥಿಂಕ್ ಈ ಡಾಕ್ಟರ್ ಎಷ್ಟು ಬೇಕು ಅಷ್ಟು ಏನು ಸಾಕು. ಸೊ ದೆನ್ ಕಮ್ಸ್ ಮುಂಚೆ ಏನಾದ್ರು ಆಗಿತ್ತ, ದೆನ್ ಯು ವಿಲ್ ಟೆಲ್ ಸರ್ 10 years ಬ್ಯಾಕ್ ನನಗೆ ಒಂದು ಸ್ಟೆಂಟ್ ಹಾಕಿದ್ರು ಅಂತ ಅಲ್ಲಿವರೆಗೆ ಹೇಳಲ್ಲ. ಓಕೆ, ದೀಸ್ ಆಲ್ ಥಿಂಗ್ಸ್ ಹೌ ಇಟ್ ಕಮ್ಸ್ ಇಸ್ ಬಿಕಾಸ್ ಆಫ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್. ಬಟ್ you see, it is just nothing but presenting complaints, past complaints, family history. You see, you go according to the headlines that your professors have taught you. Even in your busy practitioner, even in your whatever you are, always take good history, then examination, then see the reports, then order the reports. Okay, unnecessarily don't order reports itself in the first go. Okay, so then comes, this is about this thing. Then comes your cardiac imaging, like I told, 2D echocardiography can identify at early stage. And then comes your management. What is the pre-hospital care? So it all happens in US and UK, but still we can do in India also. Like if suppose the patient got MI, okay, I mean chest pain and those symptoms, immediately don't pop up because then WhatsApp message was circulating. You either drugs now, suddenly things put on. Okay, suddenly things put. Suppose if he is having something else, okay, it has happened. When the patient was having this bronchiectasis, he started coughing blood after taking the antiplatelets and those things. So the patient should be given rest and move to the hospital, take a ECG as early as possible, and then comes the control of cardiac pain. You give nitroglycerin, either tablet or the spray, and rapid identification for the reperfusion. That means you do ECG, whether the patient requires early this thing or what. So what are the first 4 drugs that you should give is aspirin. Aspirin again, derived from a plant. Okay, it is the one of the drug. It can never go from this earth. Okay, so almost 200 years, it is still. You know that I didn't have that slide actually. It was there in some other this thing. So when the aspirin was first marketed by Bayer, it was for beauty purpose, to improve your beauty and youthfulness. After 40 years, they marketed it as aspirin tablets to improve your beauty. And below they are written, it doesn't have cardiac side effect. So you can see in your Google, okay. But later they came to know that it is a drug for cardiac this thing. Okay, so like that things change over time with research and these things. So ASA, then comes your beta blockers. That means you start acting beta blockers like metoprolol, tartrate, like those things, and antithrombin therapy. That means you add either clopidogrel, and now all these days we give prasugrel and those things. And then comes to reduce the pain, give sarbitrate. Okay, then comes give heparin. One anticoagulation should be given. Either heparin, people give either heparin or low molecular weight heparin, whatever they choose. If the pain is less than 12 hours duration and patient is not having any contraindication, like there is no bleed in the brain, there is no bleed in the gut, there is no anything in past 3 months. Suppose that's why past history is very important. Okay, so whether any time he had bleeding in the this thing or bleeding PR because of so many renal conditions and those things, we should ask all those things. Suppose after giving your treatment, patient survives of heart attack and he is having bleeding per rectum, then he will tell, sir, ನೀವು ಮಾತ್ರೆ ಇಂಜೆಕ್ಷನ್ ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ಹಿಂಗೆ ಆಯ್ತು ಅಂತ. Okay, so that's why you should always ask, are you having any bleeding symptoms from anywhere? And tell the patient, since heart is important, I am giving the treatment here. it can cause some bleeding. So you should be aware of it. So always telling the patient what he has got, so is very important. So then, if he is eligible for lytic therapy, that means he had no recent intracranial bleed or anything, then you can take patient for thrombolysis. Now we have got multiple drugs like streptokinase, one for one those who are not affordable. Then comes your tenecteplase, etiplase. These are all the new drugs that are available, but their bit cost is 35 lakhs, 35,000, 45,000 like that. Okay, nevertheless, if the patient is affordable, these places are very good. Etiplase and tenecteplase. Also, tenecteplase will be soon will be made cheaper. And then if the lysis is contraindicated, okay, then we take the patient for angiogram and angioplasty. Okay, if the pain is more than 12 hours, do not thrombolize. Give all these classical 5 drugs. Okay, and then if the symptoms are persistent, then take for urgent angiogram and angioplasty. If the symptoms are lessened at your elective time, elective date, you can take the patient for angiogram. Many times what happens, we will be telling, you tumba jana bartare 40 years, 35 years. Yesterday only it happened. So the patient came in midnight. He is only around 51, having MI. So we are given thrombolysis because in night we don't have option. Okay, we thrombolized him. Morning, everything is okay. He is telling, sir, I want to go to Bangalore. So ಸಿಟ್ಟು ಬಂತು. ಎಲ್ಲ ನಾವು ಮಧ್ಯರಾತ್ರಿ ನಿದ್ದೆ ಎಲ್ಲ ಕೆಡಿಸ್ಕೊಂಡು ಮಾಡ್ತಿದ್ದೀವಿ. This fellow wants to go. No, we will do angio. He is telling, no, in Bangalore only I will go. Somehow I made him to convince. Then we took for angiogram. Nothing was there. The vessel is recanalized. Okay, the drug has acted in such a way that it was a soft clot. That's why it went off. So otherwise, what happens if there is a atherosclerosis? As I told, like it is having fibrin core and all those things. The tough lesions will survive and will be there. Only the platelet and clot part will go. So then you can do angioplasty and stenting. Okay, this guy was having only 20 to 30% blockage. So we told no, you can undergo just medicines only is enough. Okay, so that's the good thing. Like we are saving such patients and doing things here possible in Ballari. As sir was telling, golden hour, time is muscle. Time is gold ಅಂತ ಹೇಳ್ತಾರೆ ಲೇಡೀಸ್ ಅವರು. ನಾವು time is muscle ಅಂತ ಹೇಳ್ತೀವಿ. Okay, so why time is muscle? Because so the earlier the patient comes, earlier you make diagnosis, earlier you do these things. Okay, so then there will be a better chance of you are saving more myocardium, and in future you will not go into myocardium scarring and LV dysfunction. Okay, so it is called like benefit. The benefit is maximum when the patient comes within 2 hours. This is very rare in India. Okay, they will take they will take pantoprazole, they will take so many things. Sometimes they will take buttermilk. Okay, and they think my pain will go away. Okay, so there is less education, but only few people will come. Actually, real patients will not come. Unnecessary people will come and they will do ICG, everything, and then they will tell one big word. Sorry, ಇಷ್ಟೆಲ್ಲ ಮಾಡಿ ವೇಸ್ಟ್ ಆಯ್ತು ಸರ್ ನನಗೇನಿಲ್ಲ. So we have to be very careful about these people, and we should tell them, I think it's not there, but still you want to do, I will. Okay, so then patient belief will also increase, and you will also be doing more scientific things. You see, what I am telling is scientific things. Your mind will be more peaceful, your mind will be more this thing only when you are doing scientific things and ethically based things. So only then our mind will be more free of any guilt or anything. So this is called something called door to needle time. What we tell is, so suppose the patient comes, within 8 minutes ECG should be done to any hospital, and then within 15 to 20 minutes all the antiplatelets, everything we should give, and tell the patient, assess the patient. If there is no bleed anywhere, if there was any past history, take everything. If nothing is there, then you should start the streptokinase or reticulase or whatever within 30 minutes. This is the ideal goal. So they have set particular time. Actually, now it is subdivided. Within 8 minutes, somebody should take ECG. That means don't take ECG for everyone. Okay, whoever comes with your angina. So your everything starts from again second year, whatever you are read in MBBS or BAMS. So history taking. Okay, then comes your door to balloon time. That means patient is rich, affordable, and you have got all these things, and you can do angiogram, angioplasty. So from the attending the hospital to the till the guide wire is crossed across the lesion and putting a balloon and dilating, that should be 90 minutes. When that is possible, then do angioplasty. Okay, these are all some standards they set, because only when we set standards we can do the things. Okay, so then comes your unstable angina, how to manage. ST elevation MI, as I told, unstable angina. So always give that same 5 drugs. See the patient is, becoming settled down, pain is settled, you can take it as elective. If the patient is stable and ECG is not showing much changes and still you are in doubt, TROP-T negative, then take the patient for TMT. Okay, if the TMT is positive, only then you are more scientifically evidence that he has got these things. So if I open an artery, then it will be beneficial for him. Okay, so then comes your chronic stable angina, and always remember this ABCD drugs. Okay, this is one this thing. A means aspirin and anti-anginals. That means nitroglycerin and those things. So next comes beta blockers and blood pressure control. Suppose so yesterday we had an incident like patient was having 240 by 140 BP. He is having MI also. Suppose in this case, if I thrombolize patient, he will bleed here. So what we did was first control the BP, the LTG, this thing, and then thrombolize. Okay. Then blood pressure control is that's why very important. So ideally the BP should be maintained less than 180 by 90. Systolic 190, second is 90. Okay. So if below less, then below that number, then you can thrombolize or give heparin and give all those things. Then C means cholesterol controlling drugs and stop cigarettes, and D means diet and diabetes control. And next is education and exercise. Always we should educate patients. To educate patients, always we should educate ourselves. So always you should be reading. Okay, whether it be the habit or whatever, whether it is whatever. So try to open up when you are a practitioner in future or whenever wherever you are. Always have a habit of reading scientific journals and your classic textbooks. Never forget them. Okay, then comes your prevention. I know everybody knows that how to control this thing. As earlier I told, like LDL more less than 100 and other things. Okay, so thank you very much. So any practical question you can ask, so we can take. Theoretical you read from book. No issue. I will stand up. Any question? Anything? It can be silly also. So today I think everybody came to know there is always one diagnostic lag and therapeutic lag for any test. That means ಈ ಕೆಲವರು ಬರ್ತಾರೆ ಅಬ್ಡಾಮಿನಲ್ ಪೇನ್ ಅಂತ ಬರ್ತಾರೆ ಬಂದ ತಕ್ಷಣ ಆಮೇಲೆ ಸ್ಲಿಪೇಸ್ ಕಳಿಸ್ತೀವಿ ಆಮೇಲೆ ಸ್ಲಿಪೇಸ್ ಪಾಸಿಟಿವ್ ಸಡನ್ ಆಗಿ ಆಗಲ್ಲ ಇಟ್ ಆಲ್ಸೋ ಬಿಕಮ್ಸ್ ಪಾಸಿಟಿವ್ ಓನ್ಲಿ ಆಫ್ಟರ್ 4 to 6 hours. That amylase lipase should be released into blood and it should be able to be evaluated, detected by machine. Okay, everything takes time. So all the tests they have got diagnostic lag. I mean, not that immediately you give the treatment, everything becomes normal. Suppose pulmonary edema disappear agide, ನೀವು ಲಾಸಿಕ್ಸ್ ಎಲ್ಲ ಕೊಟ್ಟು ಚೆನ್ನಾಗಿದೆ ಅಂತ patient ಅಂತ ತಕ್ಷಣ ಎಕ್ಸ್ರೇ ನಾರ್ಮಲ್ ಆಗಲ್ಲ. Suppose tuberculosis cured also, it will not disappear from X-ray. It will be there for some time because that all the calcification, whatever the things have occurred, that will be there. That is called therapeutic lag. So these are 2-3 things, okay, that you should know. Anything, any question? Okay.
Good afternoon, sir. So what is your opinion of using statins on long run? Is there any side effects that we have to
Long run. Yeah, madam, statins, to be honest, there are so many things. Like statins, market driven and all those things, people tell so many things. Suppose if the person has got MI and diabetes is more than 40 years, these are the only 2-3 indications where the professional bodies have advocated for statin lifelong. Okay, but lifelong statin, there are many side effects were seen. So we use doses. So what is the dose for newly detected some coronary artery disease or any atherosclerotic artery disease clinically? So then always give moderate and high intensity statin. Moderate for atorvastatin is 40 mg, high means 80 mg. So moderate to high under 40 to 80 mg, depending on the tolerance. Many of our Indians, they don't tolerate 40 mg statin. They come with muscle pain, what we call as SMSI ನಂತರ skeletal muscle symptoms associated with statin one term here. Okay, like they will be not having myositis, but they will be having what you say, like muscle pain, and if you do their CPK, it will be raised. Okay, these things are common with statins. So that time what we do here, you see the patient has got MI and these things, definitely they reduce the dosage. If you are giving 40 mg, make it 20 mg. Again, after 2 to 3 weeks, measure the CPK. If it is normal, you can continue. Again, if it is raised, patient is having symptoms, again you can reduce. But the most common statin-associated symptoms were more common in people who are having less vitamin D3. Most of the Indians will be having less vitamin D3. I came to know about mine only few days back. Okay, everybody's D3 is low because we don't walk in sun. Okay, everybody is in AC room or we are working inside only, under the shades. So vitamin D3 less, hyperthyroidism, and some congenital muscular disorder. These patients are more likely to have statin side effects, muscular. Then comes in liver patients, always we should use the lesser dose of statins. Okay, there were studies like if you give long-term statins, so people started thinking, if I take statin even without disease, I will live forever. That doesn't happen because statins can induce de novo, new onset of diabetes in such people. Okay, those are not having diabetes. It has been shown. So then, like they started some dream study and those things. Actually, they thought if we give some 2-3 drugs, we can prevent the coronary disease for lifelong. They did some studies. Westerners, they do so all these kind of studies just to see that whether it really was. You see, what I was taught in my DM was negative studies you should concentrate. Negative studies and where the trial outcome is negative. It is very difficult because the pharma industry is sitting behind you. Okay, and they are advocating get some positive result. So always negative these things uh, studies are very important in life. Okay, they shown like it's not beneficial in normal people. Only if the cholesterol is more than. So now they brought the cut down to 130. Okay, above 130, you see in the guidelines also it's clearly written. Okay, you just see NCEP guidelines from American Heart Association. What they write is only first is lifestyle modification. But who wants to do a lifestyle modification? Nobody wants to work. Nobody wants to do diet modification. Everybody wants the drug. Okay, so that's why the pharma industries are booming. Okay, so more than 160 only you should start the drug. Otherwise, in if any risk factor is a single risk factor, if there are no risk factor, only more than 190 you should start a drug. Many people come, they'll be thin on these things, they just want to test their lipid profile. 190, I tell them do walking, all those things, repeat after 3 months. Okay, many times it comes down just by simple diet modifications and simple things of avoiding some sweet and something when you go and go for any function or anywhere. Because in our India, any function means sweets, fried items. Okay, so all these things they have to cut down. Only then it will come. But it is very difficult. But everybody wants to take a drug. It's very easy to solve. Okay, so statins definitely they have got long term. One is liver toxicity, muscle toxicity, new onset of diabetes. These all things we should always monitor when the patient is receiving for a particular indication. Okay.
Namaste, sir. Thank you for joining the session. My question is that as you mentioned, the patient is asymptomatic with any symptoms, but his biomarkers are raised. It accidentally or it is a fashion of blood investigations randomly. So it is elevated or some abnormalities are found in the reports, but patient is asymptomatic. So which one, like, what we have to do?
No, it happens sometimes. I have seen people coming with troponin I positive. They come to me, sir, no test ಮಾಡಿಲ್ಲ. So then he is like, do troponin T. If the urea creatinine is normal, repeat after 12 hours. Then also if it is not raised, okay, but still the patient has got doubt, you have got doubt, do ECG, do echo, do TMT. Okay, if all the three are negative, why you want unnecessary treating? No need to. So always, if somebody is suspected like this, troponin is many times I see false positive coming. Sometimes in our Jairava or Mandana sir used to say, yes, so walking mad ಬಂದ್ರೆ troponin positive ಬರುತ್ತೆ ಅಂತ. So in fact, I did a study where TMT ಮಾಡಿದ್ಮೇಲೆ it used to come positive even in normal people. So whether the cutoff values have to be raised after exercise. So there was one discussion going on. But unfortunately, though we gave data, everything didn't get published. Okay, but these things are seen. Troponin I, that's why people think it is less sensitive. Okay, I mean less specific. Sorry, less specific. It is very sensitive, less specific. But troponin T, if it is positive, means you have to give due respect to it.
So, but this whatever the troponin levels are, only when cardiac muscles are damaged.
Yeah. Only then. No. It's not like even a normal person like me and you. Some troponin levels should be there. Otherwise, we are not. We don't have heart. Okay. Because some muscle repairing will be occurring. Some muscle repairing will be occurring. So troponin is to be released. That's why I told HS troponin test means it should be able to detect troponin either I or T or C. C is still not yet commercialized. It's still in only research labs. So it should be able to detect that troponin even in a normal person. So then they do all these studies that mathematics again comes in, statistics. So that Gaussian distribution. So 2 standard deviation is ಜಾಸ್ತಿ. So that value comes as 14 nanograms for troponin. Troponin I, it varies from each lab to lab. Why? Because troponin I multiple detecting epitopes. So based on that, for example, when I was working in Badavi, initially we got on a mission. It was a Korean mission. It used to give positive many times, but we started believing less in it. So believing on more of our clinical skills and then sending. So you see, in the night time, what happens? Amrut lab was closed. So there was no other way to get troponin T. Now at least I think in 3-4 places we have got troponin T testing these things, these Roche machines. Okay. So troponin T definitely is helpful in such situations.
So can you throw light on ultra-sensitive CRP?
No, madam, they tell so many things, HSCRP, ultrasensitive CRP. Only by doing these things, what we are doing is we are making people dependent on more on drugs. Hello, sir. We are making people more dependent on drugs rather than, but definitely they indicate, HSCRP, definitely it indicates there is some inflammation going on in body. Okay, HSCRP along with something, like along with some diabetes, along with something else. Then you can say that person is at high risk for some atherosclerosis and those things. Otherwise, even if you have some cold and cough, go and test HSCRP will be raised. So it is an inflammatory marker. Many times it is raised. When the cold and cough, some bacterial infection or viral infection, HSCRP will be raised. False positives. That's why we should know when the false positive occurs of every test.
So which one would be more precise, one particular parameters we can rely on?
For what? For MI or this thing? For atherosclerosis, no, none of them. Everything is a combination. Combination of history, like what is the family history and those things, then patient history, then this what you say lipid profile and multiple combination of all the things. Just you can't rely on one thing and tell you have got something. No, the only way is cutting open and seeing in microscope, but that's not possible. Okay, so not single thing is reliable. Okay, what I do practically is many times people come here in Ballari, so many people have got fire. Particularly what happens if one of their friend dies suddenly because of some heart attack or something, they will all those people will get all the tests and they will come to us. Sir, nodi hengide. They will hire a cab and all the people will go to some Bangalore, some good hi-fi hospital, get all the things done. Okay, this trend is there everywhere. So many times I tell them if you don't have symptoms, if the LDL is okay 160, just do diet modification, lifestyle modification, those things. If you got diabetes or not, you control it. Or if you diabetes, only then take statin. Otherwise, why you want to take? Okay. So it is a combination of everything, what I said. So only then we will be able to do justice to the patient. Okay. There is something called justice to the patient and justice to our practice also. So we should be always doing that. Okay. Anything? I thought somebody will ask this question you asked. Okay.
So how can we prevent it? And secondly, we can see increased death rate in these younger adults. So how can we just see it from investigation point of view and lifestyle modification?
I will tell. Okay, just I will tell. Since the Puneet Raj event, people are telling after Corona, after these things, this has come, that has come, people are dying, young people are dying. It was there even before. Even your people also know who are practicing. We also know. Like, so there was young heart attack in young was always it is there. It is not like it was not there only after Corona vaccine it has come. Okay, so definitely, so many people they want to find a scapegoat, they will find it. Okay, so young people like this particularly, if you take that Puneet Rajkumar episode only, his brother had a stroke, his father had a stroke, so he should be more aware. He should have got his this thing, lipid profile and all those things done. Okay, and one more thing is fitness is not always equivalent to health. Fitness is different. You might be climbing Everest. It need not that your heart is healthy. Okay, health is different. Many times we see people with the big stomach, multiple all the habits, everything. If you do their LDL, it will be 80. As it. Okay, they are mentally cool here. Okay, he says something like that. So these things like it varies. You see some people. There are multiple things. It's not just your lipid profile and those things. Stress, physical stress, mental stress, lipid profile, smoking, your genetics, particularly. What's your family history? So recently, one of my friend, who is only 1 year younger to me, he was running beside Sheshadipuram Apollo. Okay, he is a marathoner, running 40 kilometers once or twice in a month, and regularly 10 kilometers. Luckily, when he was running beside Shesharupuram Apollo, he had chest pain, ECG, MI, 2-3 AV of ST elevation. So taken for the 100% occlusion of right coronary artery. He was this thing. So recannulation was done and he was put on, the stent was put. Okay. So why these things happen means there are always, you see, everybody, including you, me, everybody will be having that fat streaks, and how the fat streaks are evolved into the atheromatous lesions and those things, it will be there. Only few people where they are unstable this thing, and when then natural things like stress and all those things when they combine, so then the person will have MI. So that's why young patients, why we are seeing, because many times this sedentary lifestyle is this thing common. Nobody, you see anybody. So when we were students, you must be knowing. In whole hostel, only 1 or 2 fellows used to have two-wheeler. Okay, otherwise 40 everything we used to walk. So now, so you just move out of from one hostel block to another hostel block. People take bikes. So walking has become less. So that's why we should always use our legs more. Okay. Inside the hospital also, many people will be using lifts. Avoid that. Just do simple physical activity. Gym ಮಾಡಬೇಕಂತೇನಿಲ್ಲ. So you do simple things. Okay. Like walking in your this thing. Okay. Try to, if you are going to go for shopping nearby, go by walking. Okay. Okay. So those things definitely will prevent the things. Okay. Otherwise, why this young people MI, the most common cause is lifestyle and stress, mental stress. You believe it or not, 35-year people, software engineers having MI, and many times in Jindal also we see many people. Even without that also many times we see. So a few days back, one primary school headmaster came, around 42 years. I couldn't imagine. He's thinner than me, he's fit than me, everything. But why is that? Headmaster is also very stressful job in government setup. Okay, they'll be having a lot of people. Okay, so like this stressful life that has come. That's why again I tell pranayama, yoga, this all our traditional things, those things which relaxes our mind, and simple physical walking and these things that will prevent the things.
So coming back to statins and aspirins, when a patient is on that for a very, very long period of time, as you have already explained, is there any chance that we can completely stop them?
No,
Is
no.
there any chance?
If what we say is
After bypass surgery or something?
after bypass surgery, after MI, no.
No, there's no chance.
No chance of ecospirin and statin. Why? Because the studies have shown. So you see, GIST trial, that was the first trial that was conducted in 1972, first clinical trial. I was not born. Okay, so that time it was conducted. So they found from that time also they are following up the patients. Whoever stops, they are getting the events, recurrent events somewhere, something. So it is for secondary prevention. So it's secondary prevention is once the cardiac event or some atherosclerotic event has occurred, like stroke and this thing. You'll be getting many times stroke patients coming to you. So please do not stop ecospirin and aspirin. I mean statin until otherwise there is some bleed inside, some contraindication is there. Otherwise, don't stop. So that's why we tell ecospirin indefinitely. That means till the patient is alive. Okay. So and statin also almost in low dose. If the lipid parameters are low, definitely you can continue at low dose 10 mg like that lifelong.
So last question. This is a like big one. We all know about olive oil, avocado oil, sunflower oil. Everybody is talking about these oils nowadays, like cold pressed oil and all. So what, according to you, tell me, like, suggest some 3 best oils, sir, and what is the quantity of that oil a person should take?
Okay, this is very tough question. You see, like always, life simple questions you answer. Okay, but still I will try to answer because there is some guy called, I forgot his name. He's very famous entrepreneurist in Mumbai. I follow him regularly, his talks and those things. So one around 15 years back, he used to tell, when I was PG student, he came to Bhopal. He was telling, no, the coconut oil is the killer. Okay, now he is only propagating coconut oil is very good. Okay, these keep on happening. And then somebody actually interrogated him in one of the presentation. So that time you told like this, now you are telling like this. Then they did some studies actually. So what they are telling is none of the oil contain everything. Okay, so what they tell is best is blend the oil. But now Indian government has allowed to blend 2 oils, like either safflower oil and rice bran oil. Like that you can blend only 2. But in some Western countries they are allowed to blend even 3 oils also according to the what is the content like that. So now mustard oil is almost they are about to ban in India because mustard oil is causing many gallbladder cancer and those things, especially which is more commonly used in particularly Madhya Pradesh, Bihar, and those things. So mustard oil is at the verge of getting banned. And the second thing is like mixing two oils is good. Suppose you are unable to mix, even company is not mixing. So what we can do is rotate. 1 month you get Safola rice bran. Next month you get something safflower. Next month you get like that. So this is by rotating also we are going to blend in now. Okay. So that's what they suggested. And one more thing is do not reuse the oil. That means if you have fried it, so many times what happens, my wife or in any family, after they try to reuse it for next session. So suppose they fry some mirchi today, they will be keeping that oil and using it repeatedly for again and again. Okay, just to save the money. So rather than that, you can use that oil for some Devar Deepa Atara. Okay, instead of cooking it. So don't reuse the cooking oil. Okay, that's what they say. Because they get denatured and they get accumulated. So that is the one thing. Don't reheat. Don't. Recycle the brands. Recycle the contents. Okay, I think that should be. That's what the current thing tells like. Otherwise, everything is advertisement. ಗಾಣದೆಣ್ಣೆ ಚೆನ್ನಾಗಿ ಅದು ಚೆನ್ನಾಗಿ ಇದು ಚೆನ್ನಾಗಿ people tell. So ನಾವೇನಂದ್ರೆ ರೊಟೇಷನ್ ಮಾಡ್ಕೊಂತ ಹೋಗ್ಬೇಕು ಅನ್ಸುತ್ತೆ ಅವ್ರ ಅಡ್ವರ್ಟೈಸ್ಗೆ ಅವ್ರಿಗೂ ಖುಷಿ ಮಾಡ್ದಂಗೆ anything.
Thank you for the answer.
ಹೇಳ್ರಿ ನಾವು ಲಾಸ್ಟ್ ಬೆಂಚ್ ಕ್ವಶನ್ ಕೇಳಿ ಬಹಳ ಖುಷಿ ಆಗ್ತದೆ. Increased? None of the drugs. None of the drugs. None of the drugs till today have shown to increase the STL. ಅದೇನಾರ ಕಂಡಿಡಿದ್ರೆ then that will be like wonder drug.
Any supplements?
People claim so many things. Like they say you give some all this thing, what this fish oil supplement, those things, that things. So many things are there. But I think natural is better. I have seen some people naturally they are having HDL more than 60 like that, and they are very much protected from everything. So a few days back, I had a 94 years gentleman, 94 years, walking to my clinic, and he is telling such ಎಲ್ಲ ಟೆಸ್ಟ್ ಮಾಡಿಸೋಣ ಒಂದ್ಸರಿ ಅಂತ ಎಲ್ಲ ಪರ್ಫೆಕ್ಟ್ಲಿ ನಾರ್ಮಲ್ ಇದೆ. HDL was 60. I was very happy. Okay. I was then about to ask him what is your diet. Okay. So there is no drug to increase the HDL till today. But statins, as you are told, like triglyceride is reduced by statins.
Yes.
So whenever triglyceride is right, yeah, this one important thing. So triglyceride, when you should treat? When the triglyceride is more than 500, only you should treat. Otherwise, lifestyle modification or find the cause of raised triglyceride. So raised triglyceride, 5 causes. One is first low vitamin D3. Next is hypothyroidism or hyperthyroidism. Next is alcoholism. Next is uncontrolled diabetes. Next is food. So these 5 things you control, change all the things. Even after that also triglyceride is high, only then you give treatment. That's why I never, I think in 1 or 2 months, I write one prescription of what you say that gemfibric acid or whatever those drugs are available. Okay, 28, what you call. I don't prescribe. So only if it is more than 500, then only you treat. Otherwise, find out other causes. The person is obese, uncontrolled diabetes, and smoking, and all those things. Control these things, definitely it will come down. If the person is not willing to do all those things, only then you treat. In Indian perspective, they say more than 300 you can treat. So more than 300, if you are unable to control, then you can. The 6th most important common cause of triglyceride is in our Indians, genetic. You see many people having that hypercholesterol, type 1, 2, 3 are there. I think 3 or somewhere it comes, triglycerides. Okay. Those people, they will be having 1,000 and they will be walking around aramse. If you take their blood, it will be yellow color serum. It will be like looking like some what you say, groundnut oil like that. Their serum, it will be so oily. 1,000 more than 1,000 milligram per deciliter also I have seen.
Okay, sir, in one of the patients, the triglycerides were more than 500, the LDL was more than 200, and the blood pressure was 130 by 90. Still, his sugar was normal, the BMI was normal, he was completely fine, sir. He was completely asymptomatic, but the lipid profile shows this much results. So, sir, can we treat him as a risk factor for
Yeah,
cardiovascular
sure.
disease?
You have to try. So first I told no, rule out the other causes, hypothyroidism, diabetes, and all those things. If they are all not there, he's a healthy person still having these two, then definitely treat him with the combination of, if all these things are ruled out, with the one statin and this fibrates. Okay. Definitely.
And sir, what is the relation of the obesity with the lipid profile? We see that so many obese patient doesn't have any changes in the lipid profile, and still the thin or lean person have a higher lipid profile. What is the relation?
Genetics.
Other than genetics?
Genetics.
Because we find no history in the family.
They say even mental stress also.
Okay.
Because mental stress, cortisol will be raised. Okay, cortisol again causes all these things.
But sir, increased adipose tissue will increase the leptin, so
No,
doesn't
nothing
it?
like that. You see, in our India, you also make this thing. Thin diabetics are more common.
Yes.
So it is something called toffee. Somebody describes a toffee means thin outside, fat inside. Okay, that means they will thin from outside to look at, but their fat is accumulated in the liver and pancreas.
Yes.
That is causing diabetes. Okay, so even they will be looking very thin from outside. Sometimes I see patient having 500, 400 LDL also, very thin persons. So such person I had one, and I was telling him you will do some TMT those things. Before that, actually he came with an MI only. Okay, such persons also we have seen. So many times where the fat is accumulated. Now the current research says like why the diabetes is common in Indians is most of us the sarcopenics. Sarcopenia means less muscle mass. So they will be having less muscle mass. That's why they will be at more risk. Sometimes we see these people are very obese from their birth, but still they are not having anything. Everything is perfect. Okay.
So, last question. If all the lipid profile is normal and the HDL is very low, can we give the original means cow ghee for a supplement to increase the HDL?
That is quite controversial, but I don't know.
So, because in our science, the cow ghee is termed as a very much
No, you
efficient
see,
HDL
like-
increasing substance.
Now that again A1, A2 milk and all those things have come. Definitely, you see, traditionally what we are there, okay, it's always correct.
Yes.
Okay, ultimately, you see, every book, everything they say is first is lifestyle modification.
Yes.
Okay, next is medication, but none of us people want that. Even with the sugars more than 300 also, guidelines says first is lifestyle modification.
Yes.
But nobody wants to do. So thinking that nobody wants to do, we give them medication.
Yes.
Okay, that has happened. That has become vicious circle.
Yes.
Okay, there might be studies. There might be studies like
Nowadays, people are afraid to take oil and ghee because of they are fearing of
No, no.
increased cholesterol. But the cow ghee is
no,
scientifically
cow ghee is
proven that it
scientifically
is
proven.
increasing
Yes,
the
cow
HDL.
ghee, what you see like A2 milk, it's definitely good for this thing.
Yes.
To improve and even maintain the lipid profile. Sometimes they say like they have done some studies with kefir something. Kefir, I don't know. It might be like in Ayurveda. They traditionally they used to make kefir balls and they used to put in the milk and that will make some sort of curd. That is, they're supposed to decrease the cholesterol level. I mean LDL and those things. Okay.
Yes.
Definitely, it's traditionally what we are using. But problem is what these people are mixing to that cow's milk we don't know.
Yes.
And now all the cows are getting oxytocin shots.
Yes.
Okay. So we don't know how far they are good.
Yes. Thank you.
Thank you. Somebody here.
So my question is regarding preventive aspect of cardiac illnesses. Since many of most of the population is having one another diseases like diabetes and hypertension. So what are the mandatory screening tests or mandatory screening routines that you can suggest? So this has to be done and this is not necessary. So can you highlight those?
You mean to say screening test? Okay. So more than 21 years, they say like once in lifetime, test your fasting blood sugar, fasting lipid profile, and thyroid and those things. After 21 years. Okay. Less than 21 years, only if the family members are having type 1 familial hypercholesterolemia. We have seen the youngest patient in my practice after coming over years, 8 years having MI. Okay. So that is because of his LDL was 500. Okay. It was type 1 hypercholesterolemia. So very rarely we see that. Otherwise, for normal population, after 21 years, once in lifetime, check everything. Like basic thing, not everything means 100 pays Allah. Okay, just on fasting blood sugar, one thyroid, one lipid profile, and one hemoglobin, kidney function test, basic, creatinine, and LFT. This is enough, far more than enough. Or if there is some doubt, some anemia, something, then test vitamin B12 and D3. That's enough. So apart from that, I don't think other tests are going to add value anything. Like TSH is also okay. So apart from this, nothing. So apart from this, if your family member is having first degree family member is having some disease or something, then do for ECG echo and TMT. Otherwise, unnecessarily need not do it. Okay. So many people, what happens? This has happened. Like five people came to my clinic. They told us do all the tests. ECG echo TMT we want. Okay, on demand. So we did. So one person TMT everything was negative. He ran 5 minutes more than all his friends. Then he told, sir, today is the last day we will have party and I will stop everything. Okay. So everything was normal. He went. Night they had party. Night around 12:31 I got a call. Sir, edeno bartide heart attack ಆಗಿದೆ. That time I was not having a hospital or anything. I told you, okay, you go to WIMS. I will tell my postgraduates there. By the time he was going to this thing, he went there. He was brought dead. Okay. So that person did TMT negative. So here comes sensitivity of the test and specificity of the test. That's why after doing any TMT for anybody in my practice, what I tell them is if it is negative, ನಿಮಗೆ ಇಲ್ಲಿಯವರೆಗೂ ಹಾರ್ಟ್ ಡಿಸೀಸ್ ಇಲ್ಲ, ಮುಂದಿಂದ ನೀವು ನೋಡ್ಕೋಬೇಕು. Okay, that's what the test tells. So that means the sensitivity of the TMT test is only 75%. It can detect the disease only 75% of the times when the patient has got a disease. In 25% it's a miss. This fellow, so-called VIP, was VIP also. Okay. Next day again 10 people came and they were discussing for 1 hour, sir, how it happened, how this happened. Okay, as a doctors we need to discuss. Okay, we can't just tell aget bidre anta annakagalla. So you have to tell itara agirbodu, itara agirbodu. You see TMT test, even today angiogram is done normal, next day they are going to have MI. That also we have seen. So why? Because there are so many subclinical plaques which were not visible on that day. Okay, then now came IVS andella bandida, OCT anta bandida. Intracoronary you take the ultrasound probe and you do the ultrasound, you do the OCT. ಈಗ ನೀರ್ಸ್ ಅಂತ ಒಂದು ಮಾಡ್ತಾರೆ. In Chennai there is one center where do all these things even for normal people, just to detect they are doing some research based studies like how in Indian population coronary arteries and those things. Okay, ನೀರ್ ಅಂದ್ರೆ ಈ ಯಾರು ನಮ್ಮ CV ರಾಮನ್ ಎಫೆಕ್ಟ್ ಮೇಲೆ ಒಂದು ನೀರ್ ಅಂತ ಒಂದಿದೆ ಇಮೇಜಿಂಗ್ ಅಂತ. So that imaging they do. They also they try to find out like even early plaques. Okay, there is no test like which is going to prevent. And now we should tell the patient, once our patient name doubt ಬರ್ತದೆ, ಇದು ಮಾಡಪ್ಪ ಅಂದ್ರೆ ಸರ್ ಯಾಕೆ ಮಾಡಿಸ್ಬೇಕಂತಾರೆ, ಅವಾಗ ಹೇಳ್ಬೇಕಾಗುತ್ತೆ. See, one test is not going to detect everything, so I have to do multiple tests and see. So when if it is not necessary, you tell it's not there, clinically not required, then why you want to do? So there is no perfect screening test for cardiac disease, but still basic minimum we can do this much. If your first degree relative or somebody or person is having diabetes, so once in 3 years, once in 5 years you can do TMT. There are no late guidelines like when you should do. But once in 3 years, but some people are there. Every month they come and tell, I want to do TMT. I tell him, ಹೊರಗಡೆ ಓಡಪ್ಪ, ನಾನು ಮಿಷಿನ್ ಮೇಲೆ ಹಾಕೊಂಡು ಓಡ್ತೀನಿ. Okay, so that is also good. Okay, so such people it's not necessary. We have to educate them. It's not necessary. You see that stress itself can cause true MI someday. Alva.
So are there any particular suggestions for all the cardiac or all the risk for cardiac diseases like hyperlipidemia and diabetes and hypertension in combined? So what are the specific diagnostic sets so we can do?
So diagnostic I told us is basic blood tests are enough. And only if diabetic or hypertensive, once in first time you can do a DMT and see. Okay, many times what happens, they say like diabetes ಇರ್ತಾರೆ, diabetes first time diagnosis ಆಗುತ್ತೆ, ಅಲ್ಲಿವರೆಗೆ ಜೀವನದಲ್ಲಿ ಓಡೇ ಇರಲ್ಲ. ಅವತ್ತೇ ಔಟ್ ಫಸ್ಟ್ ಡೇ they want to run 5 kilometers. Okay, and they come with MI. We have seen many times happening. So why it happens on lifetime alle ಓಡಿರಲ್ಲ, ಅವತ್ತು ಹೋಗ್ಬಿಟ್ಟು first time they will run. Okay, that too after smoking a cigarette. So you will have MI. This has happened. One person, he never went to gym and he was doing gym. He was relative of one of my doctor. So he told first ಹೋಗಿ ಎಲ್ಲ ಒಂದು 15 sets ಮಾಡಿದ್ನಂತೆ. He got a chest pain. He thought some breath caught ಆಗಿದೆ ಅಂತ ಹೇಳಿ ಮತ್ತೆ he smoked again one cigarette. Then again he did. So he started sweating, he collapsed. Then he was brought. We did CPR to save him. It was some noise or something. So then we did angioplasty, everything in that go only. Okay, like these things, we should in life always steady. Okay, so that's why I tell like diabetes, if they want to start a exercise regimen, do one TMT. If TMT is negative, go on. Okay, in that situation, if he has never exercised in this thing, so that's why you see now in all gyms after this Punit Rajkumar event, they are putting a caution and they are taking undertaking also from everyone who joins gym officially. So like if anything happens, these things I don't have undertaking, I have to give. So because they will get what you say legal point. Okay, so ideally, so anybody who wants to start up, suppose he doesn't want to do any test means, always start slow. First walk 1 kilometer, 2 kilometers for 1 week, 10 days. Then you are comfortable, then make it 2.5, 3, like that. Okay. So the otherwise clocks are there, they can rupture anytime. I'm not I'm not creating fear in you, but I'm telling you. Okay. Okay. Okay, sir. Very thank you. Welcome.
Thank you, sir. Your passion for the subject was truly evident, and your experience and insights on ischemic heart disease has captivated all our audiences. And so we are really grateful for the time and effort that you have put into to share your experience and knowledge with us. So now I would like to invite Dr. Amresh, second year PG scholar, to render vote of thanks.
Good afternoon, everyone. Gratitude is the sign of noble souls. Expressing gratitude can be rewarding, way to thank others for their generosity or to remind ourselves of how much we have to be thankful for. On behalf of our college, I would like to extend our heartfelt gratitude for taking the time to share your valuable insights with us today. I wholeheartedly thank our guest speaker, Dr. Narendra Gowda sir, for wonderful, enlightening, informative session. Thank you, sir. I thank our principal, Dr. Madhav Digavi sir, as your for your time and energy in organizing Dr. M. Ishwar Reddy Memorial CME series. Thank you, sir. I express my gratitude to Dr. Rajshekar Ganigir sir, Professor and Head, Department of PG Studies in Travaguna. I thank you, sir. I express my heartfelt thanks to all NIMA members, professors, PG scholars, and interns for gracing the event. Thank you, one and all.
Yes.